everyone. Um, so we are going to start with our first session of the day. So first I would like to invite the chairpersons for the session, Professor Manmohan Singh, Professor Sachin Borkar sir, and Dr. Hitesh Gurjar sir. Yes, sir, yes. Sir.
A warm good morning from all of us from the organizing committee. We welcome you all to the annual Neurotrauma Conference. And we'll start the session. Some of our speakers are yet to reach, but we'll start with Dr. Bipin Chaurasia, who will talk on neurosurgeons follow the guidelines, a world-based survey on severe traumatic brain injury.
Respected chairperson, dear colleagues and friends, good morning to all of you. Good morning to all of you. I am Dr. Bipin Chaurasia, consultant neurosurgeon from Nepal. My topic is: do neurosurgeons follow the guideline on severe traumatic brain injury? Introduction. According to WHO, TBI will be the third leading cause of death in the world by 2030. Most of the TBI occur in low middle income country because of the poor roads condition and poor traffic conditions. Severe TBI potentially affect around 5 million people. Around 8% of all the TBI is severe at the time of presentation. Several versions and conditions of guidelines for the management of severe TBI has been published over the last 25 years, helping to define treatment standards and improve patients' outcome all over the world. We aim to assess the overall adherence to the Brain Trauma Foundation guidelines both in low and high income countries. For this, we divide a web-based survey on the Survey Monkey with 12 questions and with representative image of the CT scan of severe traumatic brain injury. And we got total of the 114 responses. From them, we included only 803 and excluded 11 responses which were not from the neurosurgeons. And the most of the responses came from Italy and India, and followed by Germany and Brazil. And 70% of respondents were from the upper income country and only 29% from the lower middle income country. The survey showed that 80% of the respondents choose to intubate the patients and transfer to an ICU. Admission to neurosurgical ward has been indicated by 15% of the patients, and no intubation was indicated by nearly 2% of them. No statistical difference were noted between upper income country and low middle income country patients. 59% of the respondents choose to perform invasive ICP monitoring, and invasive ICP monitoring was chosen by 42% of the neurosurgeons from lower middle income country and 66% of those from upper income country because of the more availability of this device in the upper income country. Medical therapy could be selected as early, advanced, and not recommended measures. Lower middle income country neurosurgeons showed highest adherence to the Brain Trauma Foundation guidelines regarding anti-seizure prophylaxis, hydration with hypertonic saline, and mannitol by bolus administration. On the other hand, upper income country respondents were more adherent regarding both low and high dose steroid administration and continuous CSF drainage. This picture shows that head elevation and hyperventilation and deep sedation were adhered by both equally adhered to both the country, both lower middle income country and higher income country. Regarding surgical management, upper income country neurosurgeon adhered to the guideline about both early decompression and evacuation of the temporal contusion. The result of our study shows that the fundamental measure for the treatment of severe traumatic brain injury were chosen according to the guideline both in lower middle income country and upper higher income country. Invasive intracranial pressure monitoring is considered the gold standard in upper income country for patients with severe traumatic brain injury and positive head CT. Neurosurgeons from upper higher income country were more adherent to the ICP monitoring indications in the severe traumatic brain injury. This is the table which shows that monitoring is more adherent to the upper income country and more followed by the upper income country, and mannitol and hypertonic salines were more followed by the lower income country. Hypertonic saline, mannitol and anti-seizure medications are apparently used more properly in the lower middle income country. One third of the neurosurgeons from the upper higher income country did not recommend anti-seizure prophylaxis despite the presence. One of the other sources, Edward et al. Found unfavorable outcome in the steroid group. Moreover, the negative effect of methylprednisolone was more evident in severe traumatic brain injury patients. But our study shows that low and high dose steroid were practiced by the most of the respondents in both the country. The result of our study suggests significant regional difference in both the medical and surgical measures for severe traumatic brain injury, especially regarding the technology-dependent measure ICP monitoring. In lower middle income country, a severe traumatic brain injury patient may be managed with a more aggressive surgical strategy, early decompressive chemotherapy or contusion evacuation, followed by maximal medical therapy, anti-seizure, steroid and fluids, and more deferred radiological follow-up than upper income country, whereas an intensive monitoring is preferred perhaps because of the greater availability of technological devices. The limitations of our study, this is the first international survey to map the geographical variation on the adherence to guideline for severe traumatic brain injury. Nevertheless, the analyzed sample may not be exactly representative of the entire global neurosurgical community. In our survey, China is less covered due to and the lower middle income country is less represented than higher income country. So conclusion is that this is the largest survey administered to the neurosurgical community all over the world, attempting to map the geographical variations on the adherence to guideline for severe traumatic brain injury. Results reflect some major disparity in the management of traumatic brain injury between lower middle income country and upper higher income country. The different clinical and surgical behavior is mainly driven by the different conditions of pre-hospital intensive and surgical care in low middle income country. Therefore, the concurrent guideline on TBI can be hardly followed in low income countries. Considering the TBI as a global health problem, the guidelines need to take into consideration the heterogeneity of country specific resources. This is the article which we published in the Journal of Neurosurgical Sciences, where which chief editor is Marco Fontanella, and most of the authors are from the Europe. And last but not least, I want to thank you, Dr. Deepak Gupta, for inviting us to have a good talk. Thank you.
Thank you, Vipin. Very interesting study. Have you, in this survey, ICP is one part. If we take out the entire BTF guideline, what is the compliance? Which countries are following it the maximum, and what is the compliance rate? Maybe 90%, 80%. because many of the lower middle income countries do not have the technological capabilities, so they are not following it at all. They are going by the CT and they are doing on their experience rather than BTF. So I want to know if there is any subset which is following it, and how much is that percentage that BTF guideline are followed in principle till the patient come till discharge.
We only focus on the which country is following which guidelines and which country is adhere to which guidelines. So we found that middle income country are following more on the use of mannitol and hypertenixoline, whereas invasive intracranial pressure monitoring, which is the instruments are more widely available in higher income countries, so they are using more. This is what we got.
Okay. So my another question is that what is the role of steroid? Do we still have to give steroid in head injuries?
Even if
you have the
we
30% of the population world over is still using steroids. Any evidence for that?
Sir, our study also concluded that even if even if the steroid has no role, but in spite of that, both upper income and lower income are equally using the steroid. I don't know, sir, why, even if there is no indication. Other authors have also said that there is no role, even if they are using. We also use, sir.
So what is the subset of population in the upper and the lower income group? So what is the difference in steroid usage?
In steroid, both are using same. There is
That
no
is
difference.
interesting.
So probably it's the institutional practice or something which is taking precedence over BTF guidelines.
Yes, sir.
Only this image was provided, or clinical details were also given? Because clinical details are far more important in this case than one slice of CT scan.
We focus on the severe traumatic brain injury. Yeah, 3 to 8.
And this was only one representative case. There were multiple cases.
Only one representative case we given.
Uh, Bipin, congratulations for this paper. Actually, we did a Chirag study wherein we did look for the adherence to BTF guidelines. It was published way back, I think, 2015 or 16 with Seattle. And yes, we had an adherence rate of somewhere around between 60 to 70%. Just because we were a part of the study, I would say. Because so we were very strictly adhering to the BTF guidelines. And we showed if you increase the adherence rate between 60 to 70%, the ICU mortality decreases by twofold. There is no doubt about that. Now, worldwide, my understanding, I stand corrected by Dr. Matthew, worldwide, the adherence to the guideline varies anywhere between 30% to 70%. It's not so high. Now, the interesting thing is 2016 guidelines, they have come up, and they are the living guidelines now. We have a National Neurotrauma Society of India guidelines. If you go to China, I've been to China, so they have the local guidelines, but most of the guidelines are almost run in parallel. Regarding steroids, it's very controversial. There was a class 1 evidence against the usage of steroids in earlier guidelines. Now I believe it has been pushed to class 2 against the use of steroids for various reasons. So I think this is a beautiful paper you have done, and it needs to be applauded. And let's see. But my only take is that adherence to some guideline. You know, there are 16 parameters. Even if you stick to, let's say, 5 or 7 out of 16, your outcomes are going to improve.
The only problem I see with these guidelines is the bias, because if I'm following most of the guidelines, I will respond to the survey. If I'm unable to follow the guidelines because of whatever limitations I have, I will not respond to the survey. Why should I say I'm not measuring, I'm not ventilating patients? I'm a little ashamed about that. I know what the guidelines should be. I know I should be doing it. I don't have the facilities for doing it. Therefore, I will not respond to your survey. So your survey itself, if you say 70%, that's probably because 100 people who are not following the guidelines are not responding to your survey. So naturally, a survey will be biased towards higher compliance. Actually, if you look at it, it will probably be much lower.
I agree, sir. Survey has some bias. We have also not covered the China, and the most of the respondents were from upper income countries. So there may be a bias in results.
We now
Thank
thank you, Bipin. We now invite Dr. Sukriti Chauhan. We'll talk on current BTF recommendation for head trauma.
Namaste and good morning, everyone. I'm privileged to talk today, and it's a very different topic, a very dry topic: brain tumor foundation guidelines. Recommendations both for adult and pediatric. Something we can talk about for almost 2 days. I have tried to make it very brief, and the concept of presenting these guidelines is not to teach you the guideline. The concept is to create a thought that are they really that good? Should we really follow them? Should we really create our own data for our own country? And what is the lacunae in these guidelines? Basically, I have critically evaluated almost every guideline. So what exactly is Brain Trauma Foundation? They're US-based organization, highly funded by their own universities there. And then like NSI, they have AANS and CNS, and they made the joint guidelines. It's basically a systematic analysis of all evidence-based medicine on the topic. Now, what is evidence-based medicine? Is according to them, what they felt were the right articles from which they need to make a guidelines. So they went through a search of all the articles, and they just listed 189 articles to create guidelines for the whole world for all the trauma, for all the brain trauma. So basically, they have written this particular line in the document that says, this document provides recommendations only when there is evidence to support them. So now, if there is no evidence, it cannot provide a documentation for that. You got it? So what exactly is this? There is a 4th edition. There's the 2016 guidelines. For the pediatric, you have the 2019 ones. And now they said the guidelines are going to be fluid. You know, they're not going to change numbers, 4, 5, 6 and all. It's going to stay fluid. Every time they have a new topic or a new edition, they just add it on to the existing ones. So it is, according to them, it is a service dedicated to improving outcomes in TBI. And the scope of the guidelines addresses basically the treatment that we do, how much should we monitor, and how much should be that, that borderline level. How much should the CPP be, how much should the ICP be, and things like that. And their concept is a translational guideline. That's why I use the word fluid. So these are the topics. There are totally 18 topics, and they have 28 recommendations. Now, this is the basic neurotrauma, which every first-year resident also know. I would like to know how many residents are here. Okay, there's one. Thank you. It's a talk targeted at residents. Let's be very honest about it. So same thing, level 1, 2, 3. Now the only thing I want you to concentrate on is just level 1. That's the only evidence, according to them, according to us, according to everybody, which makes sense. Now what is level 1? Level 1 is RCT. It's basically, the concept is, in an RCT, you need to find 2 people with the same trauma, with the same age, with the same exact head injury, with the same mechanism of injury, and coming to your hospital with the same intracranial finding. And then you randomize it and you decide, should I give mannitol, should I not give mannitol? Now, is it practically possible? It is not. It's difficult. It's just that by chance in our country, because we have so much trauma, even without randomization, we might end up finding cases which are similar to each other. That is, if we all pull in data. So these are the guidelines. Now, you look at the guidelines very carefully. There's no pointer. Everything is level 2A and 2B. So now, according to this, level 2... Now, according to those, level 2 and 3 doesn't make sense. You cannot create any proper recommendation based on that. We only concentrate on level 1. And like and we discuss all these 18 topics. So I don't think I should be talking about each of the topics individually. We'll discuss the first topic, decompressive craniectomy, and critically evaluate only that for your understanding. And these are the topics. Now you look at the number 1, this level 1. What is it? It's a negative recommendation. So they say it is not useful. Okay, fine. We know what not to use, but what to use? Okay, fine. There is one recommendation which helps us in understanding. And like Dr. Deepa Gupta recently just now told in his talk, that there is a new recommendation that's come into level 2. So again, that power of that recommendation is lost. So these are the monitoring. Now in this, if you notice, okay, now the thing is, how many, in our 189 publications, for these 18 topics, each result was for how many publications did they study, how many patients did they study. So your question comes, I decide to do decompressive craniectomy on my patient based on how many patients study. So that might be just 300 or 500. These patients you see in a year or maybe less than a year. So these, and next we have the pediatric guidelines, that is the 2019. They're also the same, since the story goes the same. Now the irony is, these are all the charts that are available online. And if you look at it here, all the recommendations are just level 3 and a few are level 2. So basically, none of these recommendations are really strong enough for us to follow blindly. Okay. So number of trials worked on is like 189. So now question comes, an organization or an association of organizations which might be seeing less than 30 to 50 patients a month gives a rule for another set of the other part of the world which sees more than that many patients, the lowest, smallest of the center. Where is the lack in our? It's not high time that we create our own data, because we have enough data. It's just that it's like all of us know we put mannitol, all of us know we put 3%. We know if the patient is is diabetic, we don't put glycerol with mannitol combination. It's that we make our own choices and we treat, and our patients actually improve. But how many of us really want to talk about neurotrauma and do a research on that and write it, my patient improved when I gave mannitol? Oh, that's common sense here. The next question comes, when do you do tracheostomy for a patient in your ICU ward? 3 days, 4 days, yes, he'll get tracheostomy, so we have to do tracheostomy. Now, these people could not even find a recommendation. They could not even find data saying that you need to do tracheostomy on day 3 or day 5 or day 7, whatever. All of us know we do it by day 3 to day 5. But why did they not find evidence? Because nobody has documented it. But that's a normal practice for us. It's like something that we do daily. Why should you document it? That is the thought process we have. Because trauma is not a good favorite subject. We like the brainstem glioma. It's more exciting. The intramedullary tumor. So I will just critically evaluate only one topic, that is bifrontal decompression, which is not recommended to improve outcomes. However, it reduces ICP and minimizes ICU stay. That's what they said. And next, they go in for the size of the FTP. Okay, you have level 2 evidences. What they have done a rescue ICP trial to come to this conclusion. Now, that trial, in 10 years, they had 408 patients. And this is not a randomized control trial. Let me tell you, my friends, that's just another level 2 or level 3 evidence. So, can you imagine any center in India having 400 patients in 10 years? You can just get it in 6 months. Same thing, and these are the number of, just for your happiness, I counted the number of patients in each trial to come to this conclusion. Okay, so if you look at it, at least only the steroids trial has 5,000. So the negative recommendation is strong. And plus it was an RCT. The rest of them are 100 patients enough to tell us that the patient might get ventilator-associated pneumonia, or is, then next is the EVD using antibiotic impregnated, because that EVD is available only over there, so only they can create that data. So they follow that. Next is something very easy, ICP monitoring. Here they used ICP monitoring 488 patients as per the data. But if you look at it very carefully, only 1,874 patients were ICP monitored. That means the rest of them, did they do a clinical analysis and see that, was it really helpful? Is not clinical evaluation and taking a decision on surgery more important than just ICP monitoring? What if the ICP monitor says that the patient's ICP is not that high, but the patient is clinically deteriorating? Common sense suggests we will operate. So it's that way. These are the patients. Okay, in blood pressure monitoring, they came to some conclusion. Okay, fine, you need to maintain a systolic BP more than 100. So, okay, that helps us. So basically, the concept of this talk is to make you think. Now, how do you think? That's what you see. Okay, I consider myself beautiful, so beautiful me. Now, when do you see an empty soda bottle? So, since all of us are Indians, you understand that's a Goli soda pop bottle. Okay. The concept is, you assume that I drank that Goli soda, right? Because that bottle is empty. Now what is evidence-based medicine says? You do an ultrasound from my abdomen and check it's there. You do a blood test. You do a urine test. And then find another person similar to me who has that empty soda bottle in front of that person, and then do an ultrasound and everything, and that comes negative, and then randomize them. That is what is needed. But all of us already do half the work. So why not just go a little bit above the edge and do that kind of work and give the country and the world a kind of data which all of us do on a daily basis? So my friends, today I just want to convey documentation is the key. People who are working in high volume centers, we are not only saying that they need to provide data. Person in a small center with just 50 patients a month who are seeing trauma, or maybe even 30, those 30 patients you see with so much in detail, why not document and let people know if your patients are doing well? If you look at the route of going international or working in an international center, how do people go? They go to a different country and do the same data work and create their data, and it's published from there. Because if you want to enter surgical field anywhere in the world, you need to first have publications. So why is it always forced upon us? Why is it not a choice? So hereby, this is the end of my BTF dry topic talk is, if your patients are feeling good, just document it. Thank you.
Very nice analysis, Sukriti, and a good message. Obviously, multi-institutional data is the need of the hour, and India can take a lead, especially in neurotrauma. I think Dr. Matthew can elaborate on that. The problem is, again, data sharing, which is a problem, and central sort of agency who will collect it, and the willingness of each of the participating centers to contribute data. That's a big problem with multi-institutional data collection, especially in India. So, sir, you have any opinion for creating a registry?
So for instead, if you
Yeah,
already
but
that's in progress, but what I would like to add to that is, see what exactly is a systematic analysis. Systematic analysis, you critically evaluate all the data available. Now suppose I live in a small city in MP, so called Katni or somewhere, where I see some trauma. So I should make that a paper, document my 100 patients in whatever 1 year, and put it on the web. So another center does that. You have 10 articles from our country over there. So another person who is interested in all this paperwork and all that, he will do a systematic analysis of all the data collected in the country. So waiting for a registry is always a good thing. That's the best thing. I will say that's the gold standard. But till then, what about the other people who are working in moderate and small centers? So from AIMS, from NIMHANS, from CNC, we have that expectation. Yes, boss, please do some good work. We will contribute data. And next thing is, which resident who is busy with 100 patients go and enter the data? Okay, there has to be some, they have to work on that kind and make it a compulsory thing or things like that. But till then, till that happens, which we're already working on, I would request, that's why I was like, sir, like it is more of a talk targeted for the residents, that when they come out, we don't have paper, we don't know what to do, we are seeing only trauma. That was what I used to complain. But now I say that after reading BTF, I myself have encouraged you need to do some more data. Yes, sir.
I just, by the way, if you want numbers, the thing that we have, that ICP monitoring in normal CT scans, age more than 40, systolic BP less than 90, and posturing. You know how many patients that's based on? 16, 1/6.
Yes, look at that.
Huh? That's 1/6 patients.
And they tell the world. And
Yeah.
we now discuss who is following and who's not. Why should we follow? The
Okay.
question, why should we?
The question about data collection, again, the problem is you've got to have places which do reasonably the same type of treatment. You cannot have one place doing ICP monitoring ventilation and the other place has only 2 ventilators in the entire ICU for all subspecialties. You cannot collect data from both and try and present it. So, even your data collection has to be among centers with reasonably similar things. So if you're going to do data collection, you have to do tiered data collection. Places which can do everything, places which can do most things, places which are really resource constrained. That's a very difficult thing to set up to.
So we need initiatives from organizations like yours only, sir.
I think with these guidelines, it has also got a very important flip side. That is the medico-legal aspects, which we should not forget. So we make guidelines based on the higher income group countries or the bigger centers. For example, in intraoperative neuromonitoring or the ICP monitoring, for example, we make a blanket guidelines that this has to be done. So what happens to the people working in the smaller centers who doesn't have ICP monitoring, or sometimes it is always doubtful whether it really helps or not. I am talking only on the basis of the ICP, because your CT scan shows mass effect. There is a shift. There is a effacement of the basal system. Whatever we see on the CT scan, it is directly proportional to what the ICP says. If we make a guideline and one person sitting in the smaller centers, he doesn't have, so people can make a litigation. This litigation actually happened. A person who operated a tumor in the brainstem or the intramedullary, he doesn't have intraoperative neuromonitoring, and he deteriorated. He made a lawsuit against the patient in India itself. I think this is within last 1 year. So the doctor is now fighting a case in the court. So I think it is a high time we have to develop these guidelines based on our general population, especially in the smaller centers, that how they manage the patients. So we actually forget them. right?
Yes, I
So,
wholly agree.
it is very important because we have been managing these patients for the last so many decades. So we know that what happens by seeing a patient clinically and with the imaging. We, by and large, we know that what is going to happen to a patient. We all know that. And many times we cannot even follow what the other says. So sometimes it looks stupid also. So that what the even written in the guidelines from the centers, which actually do not manage so many patients, what we manage. So I think the people managing head trauma in the country, so we have to come up with the guidelines specifically to our subcontinent.
Right. I think NSI, we had a small release of a small notebook which was targeted at ER, not exactly at neurosurgeons, but even at emergency doctors. So that was kind of helpful.
Again, those guidelines actually based on the bigger centers. So we never target the people what
From
they are doing.
smaller
Smaller
centers in
centers,
India.
exactly.
Okay, okay,
So,
right,
so,
sir.
so see, always we say that it has to be done like that. So what about the people working? So if we see in our 50s or 60s, the surgical management of head injuries in the smaller centers, because the neurosurgery was irrelevant in the even state medical colleges till 90s. So it was not there. Still many centers don't have exploratory burr holes. So that used to be the standard. Nahi hai to you have to do it. So same thing is for even appendicectomy and other things. So there were specific guidelines for the PHC level or the HC dispensaries. So these guidelines still exist in our countries. So the how to manage a patient once they come to those level. So I think it is relevant to our country. So we make guidelines not based on to the 10 centers in the country, so that
Based
everybody has to follow that.
And probably we can be leading even to a rule tell the African
Exactly.
continent how to go about with
Exactly.
less resources.
We never make guidelines. So how the people are working in the smaller centers.
Right, sir.
Okay, I'll say it loud enough. The NTSI guidelines, NTSI NSI guidelines actually do that. They say compromised airway, intubate the patient. If you can't intubate the patient, put an airway door suction. If you don't have suction, turn the patient semi-prone. It's sort of stepped on. Try for this. If you can't do that, do this. If you can't do that, do this. Finally, it comes out to something that anybody can do. Putting a patient semi-prone, anybody in the world can do. You don't have to have facilities.
Thank you.
I next invite Dr. Bhatoi for his talk on CSF rhinorrhea.
Good morning, everyone. Well, from the much loved and much debated topic of guidelines, trauma foundation guidelines, and for management of trauma, and which evokes much discussion, my topic is rather plain and simple and very practical, based on my management of patients with a specific region of injury who had CSF rhinorrheas. And CSF rhinorrhea was the only problem in them, and they did not. It was not an in acute stage, so they might have come after several weeks or months. And this is what I found that the management has been satisfactory. So the approach of supraorbital keyhole approach, it is become a kind of a workhorse for the anterior skull base surgery. And this approach, to the best of my knowledge, I could not lay my hands on any of the papers which mentioned that it can be used for repair of CSF rhinorrheas. There might be a paper which I might have missed. I don't deny that. So this is what my experience is from a private hospital, catering only to a very restricted restricted number of patients, as well as the not the numbers are very small. Nevertheless, this is the hospital where I work in, and anterior cranial fossa leaks, generally we talk of from the frontal sinus, crepiform plate, crepiform orbital roof junction. This is very critical, and orbital roof also can be fractured, in which case there may be CSF leak into the orbit, and it can fracture in the ethmoid, or it may be directly from the frontal sinus going into the frontonasal duct and manifesting as CSF rhinorrhea, or there may be a compound anterior skull base injury. So the approaches so far described have been transnasal, transbasal, and all, which of course I don't have to repeat over here. But what my what I have done is supraorbital, and nothing against endonasal, but supraorbital I found that it was probably equally invasive or non-invasive, whatever you might call it. So supraorbital keyhole approach, lateral or medial, depends on what's the location of the CSF leak. And here I will add over here that the principal limitations one might encounter is the orbital groove, which takes a dip as it goes medially. So this was the incision, then gradually I started moving more and more medially, and now I do medial keyhole surgery for CSF rhinoids of this region. So this was a transciliary incision through the eyebrow, craniotomy flap, which was this size, 2.5, 1.75, free bone flap. It was flush with the orbital groove, and this is the incision marked close view, and the bone flap outlined, and that is it was initially lateral to the supraorbital nerve, but then we have been going through the more medially, and in which case the supraorbital nerve could be sacrificed. And this is the scalp flap mobilized, and the small pericranial flap has been mobilized. The temporalis has been erased off, and these are the bony landmarks, and this is the size of the craniotomy made, and the free bone flap size, it is depicted over here. So what we do is extradural frontopolar retraction initially. As soon as we do this, remove the bone flap, extradural frontopolar retraction to define the edge of the dural where the dura is going inside the bony defect, and there is a dural defect also possibly. So we first define the bony defect extradurally, and it may be there may be some difficulty in over the hump view, but then here the endoscope can help us. There will be then we see the dural opening, visualize the dural defect clearly, and see the glyosed brain. And this is one of the examples there when the orbital groove was fractured, and there was brain herniation as well as CSF leak, which was manifesting as rhinorrhea. Then a small piece of fascia lata is spread extradurally with biological glue was applied. Sorry for the typing mistake. Another patch was inserted intradurally. Then we open the dura. Another patch was inserted intradurally, spread after application of the glue, and followed by dural closure, which was watertight. Bone flap was anchored back. This is another example where initially the MRI appeared normal, but then the radiologist was very observant. He said, no, there is a CSF leak here, and this is what we found. There was a fairly fair-sized fracture defect over here into the ethmoids. Another patient, and this is the post-op picture of the patient. Another patient who had a CSF leak on the left side, and of course there will be initially might be some difficulty in getting the dura retracted over the orbital roof, but then it is possible, and it is possible to reach right till the midline. And once we reach the midline, we can spread the extradural patch of fascia. And since it's a keyhole incision, we may not get enough pericranium over here. That's why we have to go and harvest the fascia lata. This is another example in which the fracture was through the ethmoids, and these were also sealed by the same technique, post-op appearance. So total, it was a small number, 14 adult patients, but then as I said, it's a very select group or restricted group, because these are not acute trauma patients coming. They are coming much later, after months or years, months or weeks, saying that so and so had got injured some time back, but there is a watery discharge coming from the nose. There were 4 males and 10 females, right side 3, and somehow for some reason the left side predominated. Operating time was about 60 minutes, and hospital stay was 48 hours. None of these patients required a lumbar drain, and there were no recurrences, and the CSF rhinorrhea stopped forever. So this is just a very short presentation, and what I feel that it is very much as minimally invasive as any other approach for management of CSF rhinorrhea. Good results, but then these patients have to be selected for this approach. I cannot recommend this procedure blindly to everyone, but the patients have to be selected. They have to be selected for this approach, and this approach does extremely well and with very good results. Thank you.
Thank you, sir. Sir, I have one or two questions. Do the pneumatization of frontal sinus affect the choice of your approach? Number one. Number two, is there a problem with closing the dura? Because at times you cannot reach deep, or you do not intend to reach deep and release some CSF here. So is there any problem it closing a small dura which you have opened because of the frontal pole which may come out?
Yes, about as far as the pneumatization of the frontal is concerned, it depends. Most of the time, the craniotomy stops short of the frontal sinus. Most of the time, and I have done one patient who had a frontal sinus fracture in the inner table fracture, and in which also similar procedure was done. And I do not make any special effort to suture the dura at the basal defect, the basal defect of dura. If I can get suture through that, I do it. If I don't, I leave it with the fascia and the biological glue to do the job, both intradurally as well as extradurally. Whatever opening I make for the dura, I suture it very.
There is no problem closing that.
No,
opening.
there is no problem closing that. Of course, it requires little, say, hand-eye coordination, and you have to select the right needle so that it can turn in that small defect. Otherwise, the conventional needles may not be possible. Normally 40 or 50 sutures can be, or not even 40, but maybe thinner than that.
Okay, so you always use endoscope or use microscope also?
Microscope. This is purely microscope.
Okay.
I said endoscope can be used in case you are having difficulty in negotiating the hump.
Once you are actually, if there is a defect in the cribriform plate, so it is very difficult to see from the lateral side, because we are making craniotomy on the lateral. So invariably you will end up making it more medial.
Yeah.
Because you won't be able to reach there.
That's what I said. I started making more and more
exactly. So I think I tried in one. So it was practically blind. You can't see the defect.
But I think the trick is that you raise the dura enough.
I know, but thing is that again that defect is so interior, because you are again there. So your angle is not there. So ultimately either you have to drill out the whole of the inner part of the bone, or you have to extend your craniotomy, because that area is interior, very interior most.
I agree
so that angle you will never get unless you put an endoscope.
Especially the midline cribriform plate may be difficult, and this is where probably the endoscope might help us. Otherwise, but if you keep on peeling off the dura, generally you can reach the site of pathology.
I think it's very good for lateral defects.
Yes.
Defects
over
close
the
to
orbital
midline
roof.
will be difficult to deal with this.
Especially orbital roof and the junction of the cribriform with the orbit. So that is the region
because close to midline, dura also becomes very adherent to.
It becomes adherent,
and you get olfactory nerves.
And none of these cases had any compromise of the olfaction. None of these patients.
Yes, so these were laterally based defects.
Yes. Because there are many times when olfaction might be compromised, but none of these patients had compromised.
Or defects of posterior wall of frontal sinus.
Or posterior wall of frontal sinus. In fact, the posterior wall frontal sinus was a case of blast injury in which there was fracture of the frontal bone, and this was detected nearly 3 months after the initial injury.
Yeah. Thank you, sir. Thanks very much. We next invite Dr. Shweta Kedia for her talk on pregnancy with TBI.
Okay, so thank you, Dr. Sachin. And on behalf of the organizing committee, I welcome all of you again to ANTC. And I'm taking you now to a specific subpopulation of patient, TBI in pregnancy, a body with 2 lives, which we encounter very infrequently. And maybe 1 or 2 patients in your lifetime you would get to see, which has survived, managed to reach your center, and you proceed from there on. So it is very, very unfortunate when in the morning you are, relaxing, having a sip of tea, you come across such news, a pregnant woman killed in hit and run. And it amazes me how in such a diverse country like India, we have this uniformity. Most of these pregnant female pillion rider riding without helmet and has lost life. And this is not a selection bias. I just, Googled news, pregnancy and road traffic accident, and within last 6 months, so these are all the news within last 6 months that we encounter, and unfortunately all of these patients had died on the spot. So it's very, very saddening. TBI is the commonest non-obstetric cause of mortality in pregnant females, unfortunately. We did encounter such a patient last year, and it was not such a bad journey, although it was, there are few residents sitting over here. This patient stayed with us for 7 months, and I'm sure she came she went through hands of almost all of us who worked in trauma center. So woman in coma for 7 months, gives birth to a baby girl at Delhi AIMS. She was brought to the AIMS emergency center when she was 40 days pregnant, and she was with severe head injury. She underwent 5 neurosurgical interventions, and she managed to survive in an unconscious state. There were a lot of controversies, a lot of debates happening interdepartmental. With the family's consent, the decision was taken to let her continue with her pregnancy, and in the month of October last year, she delivered normal vaginal delivery, a baby girl. And obviously she could not breastfeed, so this child is a bottle-fed baby. So now going through the epidemiology, as always, we do not have a data for this, unfortunately. It's again the Western-based data that we have. It affects almost 8% of all pregnancies, and 0.3% of the pregnant women require hospital admission due to trauma, which is mostly in the 3rd trimester. The mode of injury is usually the same as we see in normal patient, so a non-pregnant patient. So motor vehicle accident being the commonest, obviously the sexual abuse, penetrating injury, and falls. There are papers to suggest that the mortality and morbidity rate in these pregnant patients is relatively higher if we compare it with their non-pregnant counterparts. Now, just a brief overview of the physiological, the anatomic, and the metabolic changes that happen in pregnancy, which may affect and which we should take into consideration when we are managing patients. So the hemodynamic and the cardiopulmonary changes that are happening, as you would know, starting from the airway. Because of the upper airway edema, the intubation may be difficult, so we consider early endotracheal intubation. Because of high metabolic demand and oxygen consumption, there are more episodes of desaturation in this group of patients. For the cardiopulmonary changes also, there is a decrease in the vascular resistance. These patients have a high cardiac output. The symptoms of shock may be masked, so we need to have a low threshold in these patients. They are more prone to prothrombotic state. They're in a prothrombotic state, so they're more prone to DVT, and so consideration for DVT prophylaxis, mostly mechanical, should be taken into consideration. There are many more physiological changes that are taking place, and we recommend a good cooperation between neurosurgeons, obstetricians, neonatologists, and anesthetists. As a protocol, we always assume that any female patient coming to your emergency room in trauma, or for that matter even in non-trauma, in the reproductive age group, should be considered as pregnant unless proven otherwise. We know the uterus is a pelvic organ, and it becomes obvious only after 12 to 13 weeks, mostly around 16, 18 weeks. So we have to have a very high vigilance to rule out pregnancy in these patients actively, and we need to screen other organs for injury. A careful obstetric history should be taken. Resuscitation of the mother, as we have read for all other topics as well, mother takes a priority and is the initial action, but here we are also looking at the intrauterine resuscitation. Now here the controversy rises. As we have already read, we do not have any level 1 evidence for any of the BTF guidelines, and we really don't know whether these guidelines holds true or not. But as I was talking about ATLS, the ABCDE protocol is slightly different for pregnant, and therefore even in ATLS, if some of you have done ATLS courses, they have a specific dedicated chapter for pregnant ladies. So ABCDE protocol is different. So airway, as I said, they need an early intubation. The gastric motility, is lowered. The sphincter is more unresponsive, and therefore the chances of nasogastric aspiration. The breathing is the oxygen consumption required is higher over here. They are in a state of hemodilution, and relative anemia is present. So the airway, breathing, the drugs that you are using in these patients also would change. So induction agents would be very different. We're using short-term inducing agents. Succinylcholine is preferred. Circulation, we need to avoid vasopressors. We need to maintain the uteroplacental flow of the blood has to be taken care of. So the recommended drug would be phenylephrine in this case. As for the neurological issues, the patient needs to be examined thoroughly as you would examine any other patient. And after you've done your ABCD, you need to expose the patient as you would any other patient, and expose supine, prone, and look for any other missed organ injury. What is other than the BT and the tired therapy of the BTF guidelines is obviously to be followed. So basically what I'm trying to say is you have to manage this patient, although with a relative caution, the same way you would manage a non-pregnant patient. Like mannitol, use of mannitol, they say that it induces hyperosmolarity in a fetus, and it may cause higher sodium level even in fetus. But wherever indicated and the dose that we do give, we do choose mannitol. We do give anti-epileptic prophylaxis for these patients because they have more tendency to throw seizures, and it is usually not recommended but suggested that you would have more inclination towards use of anti-epileptic drugs in this patient. The other part that we take care of in the secondary care is the ghost cap. So glycemia, the hemoglobin, the oxygenation of this patient, the temperature of the patient, the carbon dioxide, the PaCO2 values of this patient also needs to be taken care of when you're managing these patients. The radiation exposure, we have a tendency to, okay, she's a pregnant lady and we can delay CT scan in this patient as much as we want to, is not suggested. We generally say that a CT head, since it's away from the uterus part, the radiation dose that will be delivered to the fetus, if you're doing a CT head in a protected fetus, would be around 5 millirads, 5 rads, which is way less than the the threshold dose of 15 rads, which is known to cause microcephaly in 15%, mental retardation in 6%, and is teratogenic, oncogenic by 3%. So even CT scan is recommended. X-ray pelvis causes exposure by 4 rads, so even that is safe. So all the recommended radiology as per the trauma guidelines and the ATLS protocols, like X-ray cervical spine, X-ray pelvis, and CT head, should be done and should not be withheld. We know the radiation greatest risk is at around gestational age of 2 to 7 weeks, which is the organogenesis period. But after using the proper PPE equipments, we should go ahead. So we did that in our patient. We did have this patient undergo multiple CTs. As you know, 5 surgical intervention was planned in this patient. A lot of controversies happen when we're deciding whether it is okay to continue with the pregnancy, because you know that fetus is inducing a high metabolic demand in the mother, and there have been situations when you've seen the maternal and the fetal distress and you opt for cesarean section in a viable pregnancy. So viable fetus is the fetus is more than 23 weeks and we opted for cesarean section. We have seen improvement both in the mother and the fetus as well, in the child. So it's a call that has to be taken as a teamwork. So cesarean delivery alone or followed by neurosurgery. The anesthesia that you're going to use, the general anesthesia, if you're opting for cesarean section along with neurosurgery, that is before neurosurgical procedure, if you want to go ahead with cesarean section, that would avoid the exposure of the baby to all the drugs that they're going to give for neurosurgical procedure. But however, if you're doing a minor surgical procedure, you may go ahead. There are papers suggesting that they've used the spinal anesthesia, which may be detrimental, but yes, people have done that. Brain death in pregnant patients is another very, very controversial issue. Luckily, we didn't have to go through that dilemma in our patient, but we do not have any laws for that. there was a recommendation in 2011 by the Committee of the Ethical Aspects of Human Reproduction and Women's Health, where they say every individual has a right to die with dignity. Fetus is not considered as an individual. So we are not talking of fetus life to die with dignity or live with dignity when we're discussing the brain death in this group of patients. But a case of Catarina Siqueira, she was an international athlete in Portugal, where they presume the consent to organ donation by all the individuals in the society. And so therefore, when this patient was brought brain dead in the hospital, the pregnancy was continued and the baby delivered around 30 to 33 weeks. Led to a lot of controversies, but that was the family's decision. And yes, it is an option, and we can consider continuing the supportive care for a brain dead pregnant patient to deliver a healthy baby. So to summarize, pregnancy induces systemic and central nervous systems. This is a beautiful an article published in 2022 in the Frontiers of Neurosurgery, and it has nicely, stepwise manner, dealt with all the issues that we may come across when we're dealing with a patient, a female pregnant patient with traumatic brain injury. So proper maternal resuscitation and homeostasis and maintain the fundamental care. CT scan is a technique of choice for diagnosis. It is the technique of choice, and you should not hesitate in asking for CT scan. Fetal monitoring in a viable baby. In a baby which is less than 13 weeks of age, the survival of the fetus is unlikely, and therefore if we see there is placental abruption or a fetal demise, we do not take an effort. But in a viable baby, if you have a good setup of neonatologists, you may consider early delivery in these kids. Protecting the brain to avoid secondary insults like hypoxia and hypertension, neuromonitoring as indicated, and the drugs should be used carefully, taking into consideration their teratogenic effect, and always the ethical legal controversies would remain in managing these patients. So thank you. A very theoretical topic, but yes. Okay.
Thank you, Dr. Shweta. Very nice overview and of an uncommon topic. Just for the sake of residents present in the audience, can you just summarize the 3-4 medications which we frequently use? The mannitol, hypertonic saline, antiepileptic phenytoin, and if there is Lasix, if there is any change in the dosage or the drug for pregnant patient.
Yeah, so generally when we decide on any of these drugs, we discuss with our gynecologist and we ask them to let us know if it's a safe drug or not. The recommendations as per the literature, they do not advise any change in the dosage of the current mannitol dose that we're using. Furosemide is not recommended in general, but yes, if need arises, we always take mother as an individual patient, and whatever is needed for the best of the mother care is to be given, is to be prescribed. So furosemide is not generally recommended, but if needed can be given. And hypertonic saline, there were not papers commenting on hypertonic saline, but we do not again want higher sodium values in these patients. So in general, people have still not used hypertonic saline in this patient. So there was no paper talking about hypertonic saline in this group of patients. As we know, second trimester is usually safe. If the patient is presented in the second trimester, it's safe to go ahead with any of these medications. Anti-epileptic also, they say the organogenesis, as the organogenesis period is over, it's safe to give the anti-epileptic dose. We generally give levetiracetam in these patients, but yes, we can give Eptoin also, which is recommended to be used. So so when we are treating a pregnant lady, fetus takes a secondary position, and whatever is needed for the female patient, as in any management of a general TBI patient, would be recommended.
And regarding CT, what kind of protection?
It's just the lead, yeah. It's just
lead
the
apron
lead
over the abdomen.
Over the abdomen, covering the utropelvic area, yeah. So abdomen and pelvis.
Okay. Any other question? Yeah.
Dr. Sweta, really nice to salvage that baby.
Yes.
Is it ethical? Patient is vegetative still?
So patient is M5. Obviously not independent enough to take care of the baby. So it is a very, very controversial topic. We did have arguments amongst ourselves and amongst the department. The committee was set up. There is no So the question that is it ethical to let a motherless child come into the world and let the child grow?
Because it was not mother's choice, but
It
family's
was
choice.
not a mother's choice.
Yeah.
Over here, obviously, half the patient do not have an opinion of, okay, my organ should be donated. So we're talking about a pregnant lady discussing trauma that, okay, my baby should be allowed to live is a very different situation altogether.
Yeah.
Yes, and then the decision has to be taken. माँ को बचाए कि बच्चा को बचाए.
Yeah, thank you very much. We next invite Dr. Praneeth Kokula to talk on comparative overview of head injury in India and Europe, Center TBI experience. Dr. Praneeth is assistant professor in Trauma Center AIMS.
Good morning. So good morning, welcome to AIMS for 7th ANTC. Today my topic is going to be a comparative demographical and epidemiological study. This has been a retrospectively analysis of a prospectively collected data. So I'd be going through the introduction, study design, observations, some critical comments, and the take-home message. So we all know trauma is an emerging epidemic, and to learn about from the emerging advanced countries to optimize our outcomes and study our trauma patterns would be always an interesting thing that we can have some learning message so that we can help our patients in a better way. So this was a retrospective analysis of a prospectively collected study. The European counterpart of it had 65 participating centers which had collected data from 2014 to 2020, and there were 22,000 patients. And Indian part, JPNATC and SMS Jaipur were the part of the study, and we had about 4,000 patients. And this is a preliminary analysis where we have analyzed the registry data, where we got the demographic patterns, injury patterns, and the immediate outcomes for the analysis, but otherwise it has got thousands of variables which can be studied. Start with the age distribution. This almost correlates with the age distribution of the population. As we know, Europe population is more aging, and the trauma is more seen in the elderly age patients, which is more than 60 years, where in our country, where the most of the population is young adults, those who are commonly using the road, and we see that the most of the patients are in this group of 18 to 30. But unfortunately, we have the second peak, which is in the pediatric age group, which is less than 18, which was really worrisome when we initially analyzed this data. Going into the mechanisms, this was also something which you can extrapolate with if you have an idea about how the European population and how their trauma systems are. But for those like me who are less experienced, to me it was something surprising that their trauma, the major thing was fall from standing height, so which is common in elderly patients due to the gait issues and ataxia. That is a major cause of trauma in Europe, followed by the road traffic accidents and fall from height and assault and rest of the thing. Glaringly, in our country, it is the road traffic accidents which take a major toll, maybe be the rules, regulations, and we know our day-to-day problems with the road and the safety guidelines. The second common is fall from height, and then followed by fall from standing height and assault. So we had gone to the next step where we tried to assess it across the age, because we significantly saw that the age patterns are different. So European counterpart, it is the elderly patients which had fall, and the middle-aged patients which had road traffic accidents as a major mechanism of injury. In our scenario, it is a road traffic accident which takes toll on most of the middle-aged patients. And the second thing glaringly which we can see is in the pediatric population, there is a significant peak of injuries due to fall from height. I don't remember when I was in child at my grandfather's house or at my house, we were staying at the level 0. At that point of time, India, it was developing. We don't have multi-storied buildings, but now we have multi-storied buildings everywhere. But the safety mechanisms they use for the staircase or for the balconies or for the boundaries terrace, most of the terraces, if you see in your go back to your villages, they are open. They are not guarded at all. These pediatric patients are having fall from height because of this. We are not aware of the safety mechanisms. When we are trying to grow big, we should also grow intellectually better. So after observing this, we have started a campaign from AIMS for the safe balcony, where we want to spread this message even through with all the delegates over here, that they need to be safety nets when there are grills, and the grill height should be adequate. The spacing between the grills should be adequate so that the child can't pass through it. We have a grill, but we usually try to emphasize on the design or something else, but safety is more important. We should not have a furniture in the balcony which a child can use, but children can be very innovative and they make their own ways to jump out of the balcony. So it's not a play area for the children. Balconies are not a play area. Whenever you are taking your children, you should be there available to monitor them. Otherwise, lock them when you are not there. Balconies are not to be used by the children when you are not at home. So gender differences, it is almost in Europe, it's the fall. So both the genders do fall at the same rate. But India, due to most of the road users are males, male predominance was significantly seen. This is again something bothersome, very bothersome for us, because all their injuries are a trivial fall and they are minor head injury. For us, we have a significant injury. Severe head injury constitutes 22%, which is more than combined severe and moderate of Europe. And the second thing, the moderate is also not less. It's 13%. It is more than the cumulative severe and moderate of Europe. So we have severe injuries, we have young patients, and this is a pain and burden to the society. The same thing also correlates here. We have more contusions, EDH, and more of a midline shift, which was statistically significant. Sorry, I didn't put the values. And even the need for the surgery was significantly high. All this marked in red had a p-value less than 0.01. And similar is the mortality rate. These all go in stepwise. We need this. Trauma is something which has to be prevented. The second painful situation is we don't have a proper pre-hospital care, and we have most of our trauma is not attended by professionals. So Europe also has very less percentage of patients who had medical team with them, but still ambulance services are available for most of them. Most of the situations in our situation, we know it is one of the just a family relative or a standby person who would be bringing the patient. To coming to summarization, yeah, Europe has got a completely different problem. Elderly population with minor head injury due to fall from standing height. Something we need to work on is we need to prevent this injury in children, fall from height. We need to take care of the safety precautions. And the middle-aged road traffic accidents, this is something, a behavioral change which we need to go to the schools, teach. We had to be in the curriculum, but still this is a behavioral thing which has to be a proper safety guidelines which have been long talked but less practiced to be implemented. The severity of the injury and the outcomes have to be known to the common public so that they can take to their family and discuss about this. To close, prevention is better than cure. Thank you. Any question?
We next invite Dr. Ajay Chaudhary for his talk.
Good morning, chairpersons and colleagues and residents. Uh, in moderate to severe traumatic brain injury, the healing, recovery, and outcome is a serious concern, and various factors, biomolecules, biomarkers has been explored. My talk is on our study on role of vitamin D in outcome and recovery of moderate and severe traumatic brain injury. So moderate and severe traumatic brain injury are associated with very high mortality and morbidity. Worldwide, it is 6.2 million affected by TBI. In India, it is 1.6 million person who get head injury, and out of this, 200,000 die. So TBI is a series of pathologic process following the onset of insults. Increased extracellular glutamate concentration and increased intracellular calcium, free radical overproduction, and exacerbated inflammatory response is one of the cause of further deterioration of the patient. And these patients suffer impairments of psychomotor speed, memory, attention, speed of information processing, executive functioning, fluid intelligence, language, and visuospatial skills. And these impairments have a significant impact on their social and occupational functioning. So various factors and biomolecules have been studied and outcome and recovery of TBI. So vitamin D reduces the triggering of secondary cell injury cascade and thus reduces metabolic failure and cell damage. The rationale of a study: vitamin D deficiency is prevailing in a rapid rate in society, markedly affecting their physical and mental well-being. Global prevalence of vitamin D deficiency in population is around 80 to 100%, and it is more than 90% in Indian population. So vitamin D is a steroid hormone and it is neuroprotective. Deficiency of vitamin D can increase baseline brain inflammation, enhances the TBI effect, but effects reversal may be possible by correcting the deficiency in many of the cases. Vitamin D inhibits the cell proliferation and plays a definite role in stimulation of cellular differentiation, especially of the immune system, thereby reducing the production of inflammatory cytokines and all the inflammatory markers. And vitamin D affects the expression of other factors involved in regeneration and recovery of CNS injury, including GDNF, neurotropin 4, insulin-like growth factor, binding proteins. Animal studies has shown that vitamin D boosts the formation of new axons along with increasing axon diameter. Vitamin D appears to exert its protective effect by decreasing the cerebral edema, down-regulating the inflammatory cascade, attenuating free radical damage, reducing neuronal loss, and limiting cellular necrosis and apoptosis. All of these are plausible mechanism of neuroprotection. Vitamin D has high safety profile and acts on many pathological mechanism of TBI. So our aims and objective were to study the efficacy of oral vitamin D in improving neurological outcome in patient with moderate to severe traumatic brain injury, and to observe the effects of vitamin D in outcome in functional independence measure, that is FIM and Glasgow outcome score, FIM motor and FIM cognitive. So it was done at 6 months and 12 months after the injury follow-up schedule. The plan of work was suspected severe to moderate traumatic brain injury, assessed for eligibility. There is various exclusion and inclusion criteria which I'll describe. It was randomized then and allocated to intervention in vitamin D group, and then another was placebo group. 10 ml of blood withdrawn at random randomization and at every 2 months for serum routine hematology biochemistry. Follow-up at 6 months and 1 year for evaluation of Glasgow outcome score and FIM. Analysis. So inclusion exclusion criteria: male or female between 16 to 65 years, weight 45 to 135 kg, sustained a closed head trauma not more than 24 hours before screening, and enteral nutrition started in 24 hours after admission before initiation of a study drug. So patient, when it was stabilized and rice tube could be put, and then those patients were considered. So post resuscitation GCS score between 4 to 12, at least one reactive people. So evidence of TBI confirmed by abnormalities consisting with trauma on CT scan and indication for ICP monitoring. Exclusion criteria was a very long list for it, and life expectancy for less than 24 hours were excluded. Prolonged and uncorrectable hypoxia, hypotension, and associated spinal cord injury, pregnancy, patient with penetrating head injury, patient having upper GI bleed, bilaterally fixed dilated pupil, coma suspected of primarily due to other causes, pure epidural hematoma, pre-existing clinically significant disease or chronic condition that can be ascertained at the time of admission and could affect functional outcome, severe cardiac or hemodynamic instability after resuscitation. So these are other criteria. Unknown patients were not included in this study. Statistical analysis were done based on software Stata 11.2, and so observation and results. The mean age of 40 treated patients which were included in this study were 41, and 32 were men and 8 were women. Among enrolled patients, 67.5 were having severe TBI and 32.5 were moderate. Source of injury in recruited patient were, as described by earlier speaker, road traffic accident 70%, and fall from height was 10%, 25%, and assault 2.5%. In total, in vitamin D group, 18, and placebo group 5 were 15 in vitamin D group, and 18 in placebo group were operated. So mean level of serum vitamin D in vitamin D group were 20.7. In placebo group 20.7, and vitamin D group was 17.3, and which was increased to 30.4 and 43.5 at 12 months after therapy. And mean level of vitamin D were increased and showed a significant difference with p-value of 0.004, both control and vitamin D group after therapy. So primary outcome mean fatality ratio was 40% in placebo group and 20% in vitamin D group, which showed a significant difference among both the group. So in the secondary outcome, baseline mean GCS scores of control of vitamin D group were found to be 7.85 and 6.9 respectively, which were increased to 13.25 and 14.75 respectively after 12 months of intervention. GCS means between both the control and vitamin D group at 12 months showed a significant difference. Whereas FIM score in vitamin D treated patients were highly significant at 6 months, the other were insignificant at the time of discharge and at 12 months. Glasgow outcome score was significant at discharge, 6 months and 12 months all. Safety profile was good. There was no incidence of any problem with the patient. So mortality was compared in vitamin D group, it was less, and it was significant. So this is showing GCS at the time of discharge was significant, and FIM at 6 months follow-up, and GOSE at 6 months and 12 months it was significant. So conclusion was the limitation of this study was it was a small number of patients which were studied. A study indicates that vitamin D supplementation possesses neuroprotective effect in traumatic brain injury patient. A follow-up area of investigation could be evaluation of vitamin D and its diverse molecular pathway as a biomarker for neurological disease could certainly improve success stories in clinically managed TBI patient. We had publications on this in various journals, and one book chapter on traumatic brain injury, effect of vitamin D on traumatic brain injury. It was reference, and thanks for the reference.
Thank you, sir. So, is it ongoing then? Are you still continuing this study?
No, this was finished, completed, and we want to maybe further larger study can be done.
Yeah.
As we are seeing that vitamin D has got role in many COVID time, it was immunity also. So vitamin D was prescribed to COVID patients also.
Yeah.
What dose was used?
Initial dose was 2 tablet of 60,000 units through rice tube in all these patients, and then every week 60,000 for total period of study.
So it was on.
Follow them up for 1 year.
1 year total follow up 1 year.
So.
So any monitoring of the vitamin D levels also?
Yes, yes. Every fortnight.
But they did not increase very significantly. They did not go beyond 40 or 50.
Yes, 75 is one reasonable healthy level. So up to that it didn't come in those patients.
I would like to add to your topic that vitamin D really helps in cognition and in depression. So there are a lot of studies on stroke also and post-stroke. So the concept that you added it, you can even consider selecting the mood of the patient post-discharge. Because a lot of patients post-discharge, they have this depression, sadness and all, that really improves in patients in whom you give vitamin D supplementation. I normally do that in my practice actually.
We had our one paper on role of vitamin D in dementia patient, cognitive dysfunction, and it was also significant. So maybe it requires further exploration also.
It was given with calcium, not
No, it is vitamin D. Calcium, if biochemistry of the patient is showing low calcium, then obviously calcium supplementation was good.
So actually, I was in talk with our endocrinologist also. So 60,000 unit a month is more than enough for human adults, because most of the vitamin D is actually bound to our fats. So they get deposited in the adipose tissue. So for that it keeps on releasing into the body. So every week practice is usually our endocrinologists they do not recommend. So many times a few of the patient they can get cardiac toxicity also. So a high dose of vitamin D levels, sometimes we recommend every week or something like that. So many patients land up with a severe heart blocks also. So that is the very severe side effect of that. So they actually recommend not more than 60,000 unit in a month.
We didn't find the
violation of
safety profile, but again.
Exactly. So because it is bound to the adipose tissue, by giving it every week, it doesn't help.
Okay, thank you, sir.
Thank you.
We come to the last talk of this session by Dr. Matthew Joseph on neurotrauma ICU morning rounds. So, very interesting topic.
You want to do my talk for me? I found it a very hard topic. Huh? It's interesting. Anyway, so I tried to go at it from a resident's point of view. It's too far. It's 40 years away, 35 years away from me. So I'm going it from a faculty point of view. Okay, you're coming in to do rounds in your ICU. Okay, first thing you need to do is walk through. Okay? Very brief walkthrough. You see each patient, what's happening, okay, I think, next. Yeah, not really focusing on a patient very briefly, usually with the nurse, not with the duty doctor. Yeah. Any problem, blood pressure? GCS okay? Any change? Anything else happened? Okay. Next. Did you do this? Spend a little bit more time on the admissions who we've not seen. But again, very, very brief. Yeah. Besides what you've said. Yeah, a very brief history. What does the CT show? Maybe 2 minutes, 3 minutes. You have to scan depending on how many beds you're looking after. We have now increased 50 beds. So our neuro ICU is 50 beds, and then if you're going to spend 5 minutes on each, by the time you finish doing a preliminary survey, it's lunchtime. All right. So I finished doing the scan, then I go to the computer and look at whoever's radiology I've not seen and whatever investigations I'm interested in. This entire process for one of our units, we're divided into 4 units, takes me about half an hour. But half an hour I have a rough idea of what's happening with all the patients. Rough idea, it's not very clear. Then you go on to the detailed rounds. Okay. Rarely do we do bed number 1, 2, 3, 4, 5. You start with bed number 4 because it's the one you're most worried about. Then you go to bed number 7, then you go to bed number 1, then suddenly something happens to bed number 8. So you go, it's rarely a systematic bed to bed kind of thing. And you choose who to go to. The obvious problems, yes. But sometimes, as will come with experience, everything looks okay. Yeah, monitor's okay, this thing's okay, everybody says everything's okay, but still you have this feeling, patient smells wrong. There's something wrong with this patient. Make sure you see those patients also early, not in line, not in the bed order line. Get every day, even the patient been there for 4 days, get a brief potted history, because sometimes you don't know, you've been this thing. There are people on rounds who weren't there yesterday. So, for example, this patient would be 48-year-old man, skidded and fell off a motorcycle at 1400 hours on 16th. Okay, he was taken to local hospital, had sutures done, reached CMC 7 hours post-trauma. Arrival, his ABC was stable, his GCS at 10 by 15, pupils are equal and reacting. He had no significant other injuries. His CT scan showed small left basic frontal and anterior temporal contusions with no Bas effect, mild brain swelling, but cisterns were okay. He was not on aspirin, clopidogrel, anything like that. It is now 36 post-hours injury. We have done whatever, anticonvulsants, hypertonic saline, whatever it may be. That much. We're not talking about long history, nothing. Just a brief thing to remind everybody, hey, this is what the patient is. Okay, it literally takes that much time. Examination. This is where I think we all make mistakes. We try and, at least I try and correct it. We tend to be chart, monitor, and what whoever's the nurse or resident telling you. We don't actually, so temperature normal. You touch the patient, patient is hot. But temperature recording is normal. You understand? They tell you GCS, you do the GCS without actually checking. You check at that point, GCS will be different. Better or worse, but it will be different. Yeah. So when you're doing the exam, actually please exam. Don't rely on chart, monitor, and verbal reports. Okay. All patients, when you go to ABC, obviously, okay. Remember, airway assessment is clinical. It's not by saturation. I say this over and over again. Every conference I go to, where anywhere around primary survey it comes, I say this. The biggest enemy of airway assessment is the pulse oximeter. Because the moment the patient has breathing difficulty, your nurse will put the oxygen mask on. Once the oxygen mask is on, your saturation is good. You have a patient doing and breathing like that, saturation will be 99. And therefore the average person's response is, oh, 99 saturation. Okay, no problem. And 5 minutes later, the patient dies. Okay, airway assessment is clinical. Breathing also is largely clinical. Okay, and you go through the things. Circulation is fairly obvious, I'm not going to do. Temperature, we are very aggressive with temperature. Okay, because I think it's one of the modifiables that we tend to ignore. When we see temperature, when we see the spike, our response is, okay, send counts, send procalcitonin, send cultures, start antibiotics. We rarely aggressively actually treat the temperature. At maximum, we give paracetamol and leave it. Okay, which is wrong. You can actually physically bring down temperature very fast if you actually put in the effort. Okay? So aggression with temperature is essential. Neurological GC assessment depends on what the patient's on. I'm not going to go into the details of should you do sedation holiday or not, because it depends on too many factors affect your decision whether to do a sedation holiday or not. Pupils, movement of limbs, movement of lower limbs, we never check. It's always painful stimulus, patient localized pain, finished. Did the patient move the other upper limb? No idea. Did the patient move the lower limbs? No idea. Okay, and you discover this much later on when the patient's woken up. You discover that there's actually a deficit which you didn't pick up earlier. ICP, again, I won't spend much time on, primarily because I don't know how many people will do it. But what we do when we approach the patient, we do interventricular catheter monitoring for all our patients, severe head injuries. First is waveform. You need to have a waveform. If you've got this gentle ripples going across your screen, that's not an accurate value. At this point, you have to try and clear your catheter to make sure you get a reasonably sharp waveform. Then zero. You'll be amazed how much drift happens in a couple of hours. You know, ICP shows 11. You zero, it comes to 18. You know, it's quite remarkable how much drift from zero happens in a fluid-filled catheter. And look at all the numbers before and that happened. Very often we look, oh, ICP is 12, oh, okay, fine. But if you look, 4 a.m., 5 a.m., the ICP was 19, 21. Now it's 12. But there's a problem. There's obviously a problem, else it wouldn't have happened. The balance is important. You want to be positive balance. Same time, you don't want to overdo it. If you have inadequate fluid intake, obviously the problems of decreased CPP, volume, etc. Could be you're giving enough intake, but you've given patients hyper-responsive. If you're using mannitol, patients hyper-responsive mannitol, you can still go into negative balance. My way of checking fluid balance, generally, if the patient is okay, is look at the urosac. If it's a reasonably neutral color, good. If it's dark, you're doing something wrong. If it's too light, you're doing something wrong. Okay, one nice pale yellow is what you need. I think it's a practical way of doing things. The other problem I often see is overhydration, because the blind order is what? IV fluids, 125 ml, 125 ml per hour. You've got a 40 kilo patient lying there. That's probably double what she needs. But that's what you write blindly, 125 ml per hour, 125 ml per hour. And you get a patient who's overhydrated. Most people, that will not cause congestive failure or anything like that. What I find it causes when you overhydrate is hyponatremia. I don't know if any of you have the experience, but I'm very, very firmly convinced that overhydration, even if you're giving 3% saline, causes hyponatremia. Okay? Yeah, check serum sodium. Start feeds as early as you can. We start next day. Okay? I used to believe this is a thing I've been doing for the last 4 or 5 years. Before that, I firmly believed that all, especially severe head injuries, had gastroparesis. And therefore, if you feed the patient, it will all collect in the stomach and come out again, and patient will aspirate and all that. Actually, I found not true. Maybe 15%, 20% of patients do have significant residual volumes, but even those settle down with prokinetics. So we give feeds. Patient comes today, tomorrow the patient starts on feeds. I'm going to extubate day after tomorrow. I will stop feeds the previous night. Try and extubate or do tracheostomy or whatever it is, restart feeds again immediately. Okay, we're very keen on feeds because calories matter. There was this one paper which has never been followed up, I don't know why, by New York. I think Roger Hartle, I'm not sure, I think his paper, which showed that after adjusting for age, GCS, everything, timing of enteral feeds made a huge difference to outcome. I think not starting for 1 week after 5 days doubled the mortality for people who started in the first 48 hours. okay, as an independent risk factor. I don't know how true that is, a single paper, but feeding is definitely important. Look, okay, next part of rounds. So you've done the neurology, you've done your this thing, then you have to make sure that whatever the fracture tibia, open fracture tibia, or splenic laceration, whatever is also managed. Get relevant consultations, not because you don't know how to manage the patient, but because sometimes you don't. Even if you do know how to manage the patient, you, for medical legal purposes, make sure that people who should have seen it have seen the patient at least once. If there are infections, patients who've been there for longer, make sure antibiotics are appropriate, okay, and see what's happening. Maybe you've given culture-specific antibiotics, but the patient's still not responding. It's very, very likely, quite possible. Here again, medications, we tend to overdo it. All right? So go through each medication, say, does the patient need this today or not? Sometimes, again, if you look at the 40-kilo patient, she'll be on phenytoin 100 milligrams QATH. 100 milligrams thrice daily because that's the dose of phenytoin, which is actually 8 milligrams per kg for her, which is way wild overdose. But that's what we do. What's the dose of phenytoin? 100 milligrams thrice daily. Okay, paracetamol, 1 gram every 6 hours. For a 40-kilo patient, double the dose she needs. Okay, so make sure your doses are weight appropriate, and make sure the patient's getting what they need, and make sure the patient not getting what they don't need. Sometimes the latter is more important than the former. Okay, there'll be lots of junk going on that is absolutely not essential. My second last slide. These are things we don't look at. All of which, I keep telling my junior doctors when they join, there is nothing that happens in ICU which is too small to kill your patient. Okay, even the smallest thing, if allowed to snowball, will kill your patient. And I teach them all the horseshoe nail. Do any of you know the horseshoe nail? The poem? I mean whatever, I don't know what it is, not a poem. Okay, the horseshoe nail that holds the horse's shoe to the hoof. The thing goes, for want of the nail, the shoe was lost. For want of the shoe, the horse was lost. For want of the horse, the rider was lost. For want of the rider, the battle was lost. For want of the battle, the kingdom was lost. All for the sake of a horseshoe nail. Okay, everything all problems start small. If you nip it when they're small, there'll be no problem. If you allow it to grow, then it becomes a problem. So things you don't see. The number of times I've walked into the ICU, sir, ETCO2 is 35. What is the correlation of blood gas? Oh, actually, the PCO2 is 44. People are jumping up and down, giving hypertonic saline, giving mannitol because ICP is 24. Increase the respiratory rate by 2, ICP is 12. Things like that. Make sure it's done. Contractures in the limbs. I don't know what your experience is, but we find our ankles are like this by day 2, day 3. In the sicker patients, your ankle has gone like that. All it requires is when you're doing your positioning, just one dorsiflexion every 2 hours. It prevents it. Make sure it gets done. Sir, patient's awake, patient got fever. Why? There was laceration in the thigh, which is covered by the pajama, which nobody saw, which is now pouring pus. You never looked at it. Day 6, no, you never looked at the laceration because everybody forgot about it. Catheter, make sure it's anchored. Amazing how often, sir, hematuria. When did it happen? After they did change the position. Why did it happen? The catheter was hanging loose and tugged. Bowel movements, I don't know how often, again, you have these problems. We find that by day 3, day 4, patients will not move their bowels. They have great difficulty with enteric feeding. Get abdominal distension and horrible things. Make sure we've got a separate line on our monitoring sheet for bowel movements to make sure it happens regularly. Medication order sheets. You wrote this. Finally, there are 4 medication sheets, 2 sides. One has 2 medicines, the other side has 1 medicine, the other side has 1 medicine. And in the confusion, somebody forgets about the medicine. Okay? When it starts getting chaotic, reassemble it and make them rewrite as a single sheet. Okay, like I said, these are not earth-shaking things I'm telling you, but these are the little things I've found that actually cause harm. You know, these things cause harm to the patients. So I stop here. Remember these things. Good rounds do affect patient outcome. You'll pick up things. You'll do lots of stuff for the patient. That's good. Have a routine. I'm not saying follow my pattern. This is the pattern I follow. Whatever the pattern you have, you follow. Make sure that everything is covered. Okay. Do this at least once a day. If you can do it more than that, fantastic. But most people, most of us don't have the resources to do detailed rounds twice a day or 3 times a day or whatever it is. But at least once a day, make sure you go through everything that can affect the patient. Okay? And one thing I didn't mention in your rounds is, okay, one of the most useful things you can do in rounds is make sure the people who are coming after you will do rounds as well as you do. All right? Thank you.
Thank you, sir. I agree that this is a very difficult topic, but you nicely covered the practical problems we face daily. One of the things which I find is this interesting is the sedation holiday or whatever. At times when you go to the rounds, the patient is sedated, you do not get a proper GCS assessment. And then obviously that's one issue. Other times if we are managing the patient medically, sedation is a part of the treatment. So how often do you find this as an issue and how to circumvent that? The other thing is, do you use paralysis as a form of medical management or just rely on sedation only alone?
Okay, so I'll start with the last one first. It's the easiest. We don't routinely use paralysis. We use sedation. We do stepwise. When ICP goes up, first we make sure the head is elevated, neck is not twisted, all the patient not fighting mental, all the standard things we do. Okay. Then if it's there, we up the sedation. If that doesn't work, we start osmotherapy. If that doesn't work, we do paralysis. But with the first dose of paralysis, we say repeat CT scan. We repeat the scan. So paralysis is on the tiers, different from BTF. BTF starts paralysis quite early. We start paralysis quite late. We do general management, medical management, then paralysis. And paralysis, if it reaches that far, is our indication for a repeat CT. Okay. Again, change after I got intense. When I was alone, when I was looking after the ICU alone with no intensive care input, I used to use paralysis for every patient. 100%. Sedation and paralysis was the treatment for ventilation. Okay, once I got some brains to come in with me, I've taken off the paralysis on a routine basis. Sedation holiday is much harder. If you have ICP monitoring, in fact, there's a critical care medicine, one of our papers just come out on sedation holiday. When would you? Not as a evidence base, as a heat map on opinions. In critical care medicine, it's come out, sedation holiday, with ICP monitoring. So with ICP monitoring, we try and do sedation holidays every morning if the ICP has been under control overnight. If the ICP has been under control overnight, we try and do ICP monitoring. We try and do a sedation holiday the next morning, which is we don't stop sedation completely. We normally, even though it's not ideal, we still use midazolam rather than propofol because I find propofol quite expensive. We use midazolam fentanyl. We'll switch off the midazolam about say 4 a.m. and switch to propofol. 7:30 we stop the propofol. So 8 o'clock you have a GCS assessment. We switch off propofol fentanyl at 7:30. 8 o'clock we have a GCS assessment. Okay, but any point in this process when you're tapering off, the ICP starts going up persistently. 1 or 2 spikes is okay. 20 to 1 comes back down again is fine. But it goes to 20s and stays 20s. We don't do the holiday, we just go back onto our midas and sedate.
Thank you. You make it a point of fallacious reading of temperature, SpO2. But we are doing ICP monitoring in certain cases. We have found fallacious reading. ICP is showing less than 10 or maybe 10 to 15, and sometimes patient deteriorate What is your opinion regarding that?
You are doing this with what? With parenchymal or with intraventricular?
Intraventricular.
Intraventricular.
Or parenchymal also.
Okay. No. It is common, meaning false reading both ways. We have had ICP high, gone done CT scan is absolutely benign. Okay. And we've had benign ICPs and the patient's getting bradycardic, and sometimes there's a doubt about a pupil. ICP is 12. We've seen both. So ICP is not a foolproof, absolutely gold standard kind of thing. It's one of the factors that affects your management of patients. You have to look at the rest of the patient as well. Okay, I would say 90% of patients ICP is a fairly good reflection of what's happening inside, but there is a significant number of patients for whom ICP is either overreading or underreading. Okay, I can't tell you the number of times. In fact, one of my juniors said, "Sir, we should stop doing ICP monitoring because it's full of false alarms. ICP is high. You go, there's nothing on the CT scan. Normal size ventricles, sulci are seen, cisterns are seen, but ICP is high." Yeah. So it's not the be-all, end-all. Please don't go with the thing that, if you have ICP, no other monitoring is necessary. ICP is just one of the monitorings that you do. Yeah. Oh, there's lots I've not covered. There's lots I've not covered. Age, lines, ET tube. When you intubated, was fixed at 22. Now it has slipped into 20. Yeah, I mean, it's gone in deeper. It's come out. It's all kinds of things. A lot of weird things happen. I could done. Actually, when I first made this talk, it was almost double the number of slides. Only then I opened the program and saw it's only 10 minutes. So actually, A, B, C was separate. It became A, B, C, T, all became one shot. Yeah. We have a publication on our head injuries, on our neurosurgical patients, where we took high-risk patients alone, people prone, people who are sedated, paralyzed, whatever. We identified a criteria of high risk, and our sample size is 170 something, and only one patient had DVT, and this is a patient who had fracture of the tibia. Okay, we have a routine where in our ICU, all patients' positions are turned every 2 hours. When the positions turn, part of the position turning is when they make the patient supine, they lift the leg and do 2 dorsiflexions. They put it down, they lift the other leg, do 2 dorsiflexions, then they turn the patient the other side. With that, we find we have almost no DVT. Okay? Huh? No. We have 2 for 50 beds. Okay. By day 4, day 5, for the less mobile or unresponsive patients, we start if you've had a surgery. But the first 3 days, 4 days, we generally don't use unless there's a very strong indication. By day 5, we are quite liberal because we figure whatever bleeding has happened is settled, whether it's post-op or traumatic or whatever it is. But first 3... That's what I'm saying. The first 3-4 days we don't use. First 3-4 days, I rely on my nurses to do a good job. Then day 5 onwards, I allow pharmacy also to take over. Thank you.
Thank you very much, all the speakers and the audience for the excellent discussion in this session. I think we close this session. Thank you very much.
So we have gathered here for the second session of the day in Hall B. So I would first like to invite our chairpersons for the session, Dr. Shweta Kedia ma'am, Dr. A.K. Srivastav sir, and Dr. Ashish Pindra ma'am. So we'll start with the first presentation. Dr. Manish Agarwal will be talking about the concepts in the management of pediatric head injuries.
Thank you, chairpersons. First of all, I would like to thank the ANTC organizing committee for giving me an opportunity to speak here. Concepts of management in pediatric head injury. Why is it important that we should discuss about this? Because there is a high burden of pediatric head injuries epidemiologically. Then the pediatric head injuries, the children have different kind of bone and different kind of brain. So that has to be considered in the management. In the epidemiology, we have seen that there are 1 million head injuries every year in India, and death by TBI is 2 lakhs. It is the leading cause of mortality and morbidity in India. Fall from height is one of the commonest cause in younger than 5 years of age, and road traffic accident is more common in 15 to 19-year age groups. Non-accidental trauma is common in infants and toddlers. Males have a higher propensity and higher risk of injury than females. 20% of hospitalized patients have post-traumatic injury disability. In our center at SMS Medical College, in the year 2021, we had 1,151 indoor patients of pediatric age groups, out of which 402 patients underwent major surgeries. In 2022, we had more than 1,000 cases as indoor patients, and 349 underwent major surgery. In the demographics, there was a male preponderance. The mean age was 11.7 years. The maximum number of cases were due to road traffic accident, followed by fall from height, direct trauma to head, and fall of weight over head. Time interval between trauma and hospital admission, maximum number of patients, that is 65%, presented within 12 hours, and 16% within 12 to 24 hours, and after 24 hours, the percentage was 19%. So the type of head injury depends on severity and variability of initial trauma. Owing to the age-specific biochemical properties, higher plasticity and deformity, children are susceptible to wider range of injuries than the adults. In our center, the type of brain injury that we had, maximum number of patients came with concussion, 24%, followed by contusions, EDH, SDH, skull bone fractures, SH, and others. In the initial evaluation of pediatric head injury, there should be a detailed focus on the history and physical examination of children. Important factors that must be considered include mechanism of injury, seizures, loss of consciousness, headache, vomiting, ENT bleed, bleeding disorders that have been previously diagnosed, previous TBI, medications that the patient is on, progression of deterioration of signs and symptoms, and suspicious injuries such as inflicted trauma. Now there is a difference in the pediatric age group in the GCS score for more than 4 years and less than 4 years. The difference in mostly in the verbal response. In less than 4 years, we take the alertness and babbles as best score in the verbal response. And sometimes they just less than usual words and cries only to pain are the different verbal responses, which are different from the adult GCS. Now, the ATLS and Brain Trauma Foundation guidelines provide a structured and systematic approach to the management of head injury. Airway and breathing management is always the first thing that should be done, and it is same as the adult, but circulatory management is different based upon the age, because 39% of traumatic deaths in children occur due to exsanguinations. So blood transfusions is very much needed in these children, because children have higher oxygen requirement but a lower blood volume. Even more physiological reserve up to 30% of blood. Hypotension is a late clinical sign, so symptoms of hypotension are masked. We have to rely on the clinical signs such as mottled skin and other signs of hypotension. So in mild traumatic head injury, patient should be admitted if there is any suspicion of injury that may lead to further decline, such as intracranial injury on CT, depressed skull fractures, persistent vomiting, other serious concomitant injuries, higher risk of medical comorbidities, and suspicion of non-accidental trauma. These patients require admission. And if these are not present, then 6 to 8 hours of observation is necessary. In children, head injury itself can be a source of significant blood loss, unlike adult, like scalp lacerations, scalp hematoma, and skull fractures. Pediatric patient with less than 7 hemoglobin require blood transfusion with packed red blood cells supplemented by fresh frozen plasma and platelet transfusions. Now this patient came with GCS 9 and had a skull fracture with a small EDH, but the hemoglobin was 6, and as soon as blood transfusion was given, within 12 hours patient became conscious. So there are indications for screening CT scan in pediatric head injuries. Head injury inflicted when there is an inflicted trauma, post-traumatic seizure, GCS less than 14 for children for 1 year old, and GCS less than 15. GCS less than 15 after 2 hours. Suspected open or depressed skull fractures, tense fontanelle, signs of basal skull fracture, focal neurological deficit. If less than 1 year old, bruising, swelling, or laceration of the scalp more than 5 centimeter. is an indication for getting a screening CT scan. Other indications include loss of consciousness for more than 5 minutes, abnormal drowsiness, more than 3 episodes of vomiting, dangerous mechanism of injury, and amnesia for more than 5 minutes. Then there is a Pecan head CT rule which defines CT scan criteria for child less than 2 years and child more than 2 years. And the management of severe TBI is guided by the Brain Trauma Foundation guidelines, which includes guideline for baseline management, first line therapy and second line therapy. Coming to the baseline therapy, this is the flow chart, and when we discuss about this, it includes keeping the head elevated by 30 degree, keeping the core body temperature at normothermic range, antipyretics for febrile patients. Hypothermia is not very much indicated. There is a level 3 evidence for control of ICP. Analgesia and sedation also is required. The optimum dose of opioid analgesics include benzodiazepines, fentanyl and mesodolam for sedation are to be given. Fluid therapy to maintain the appropriate intravascular volume is required. Initial fluid to be started is at 75% of maintenance. Fluid of choice is normal saline for older child and 5% dextrose for infants and younger patients. Now the goals of fluid therapy include maintaining euvolmia, targeting urine output around 1 ml per kg per hour, maintaining normoglycemia by frequent blood sugar monitoring, and eunatremia. For children who are on 3% NaCl, serum sodium up to 160 milliequivalents can be allowed. Baseline care also includes starting feeds as early as feasible, ideally within 72 hours and preferably by the nasogastric route. Prevention and treatment of anemia is must, and patients with hemoglobin level of at least 7 gram per deciliter should be managed with packed red blood cell transfusion. Mechanical ventilation, if required, should be given to patients of severe TBI. Maintaining normocardia with mechanical ventilation is very important. Targeting normoxia, that is SpO2 between 92 and 99% is important. Prevention and treatment of seizure is very important in patients. The children are more prone to seizure. Studies have shown that 20 to 39% of patients can have a post-traumatic seizure. So prophylactic anti-epileptic therapy is indicated. Levetiracetam or phenytoin can be used as first-line therapies. And then the management of coagulopathy and thrombocytopenia is also important because these patients have been known to go into DIC. For first-line management, this is the flow chart. It includes the ICP management, and the evidence for ICP monitoring is suggested. Target ICP should be kept below 20 mm of mercury. If ICP remains more than 20 mm for 5 minutes, then immediate additional interventions have to be initiated, like a bolus dose of sedative or analgesics and osmotherapy. Osmotherapy can be by mannitol or 3% saline. Cerebral perfusion pressure should be maintained at a minimum of 40 millimeter of mercury. Using hypotonic saline at a bolus dose of 1 to 3 ml per kg over 10 minutes, followed by infusion at a rate of 0.5 to 1 ml per kg per hour is to be started. During hypotonic saline therapy, the target maximum sodium should be less than 20 milliosmoles per kg. Although mannitol is commonly used in the management of raised ICP in pediatric TBI, no studies meeting inclusion criteria were identified for use evidence for this use. Refractory raised ICP, failed ICP. If ICP remained elevated despite osmotherapy, additional sedation or analgesics can be given as bolus dose along with neurovascular blocking agents. However, these may lead to pneumonitis and chest complications. Elevated ICP despite the optimum dose of medication mandates initiation of second tier therapy. In the absence of ICP monitoring, we should keep the systolic blood pressure at 50th percentile of age by titrating fluids. If BP is not reaching till 50th percentile by fluids alone, then we must use vasopressors. Second line therapy consists of surgical interventions for refractory raised ICP, including external ventricular drainage placement and additional CSF drainage through lumbar punctures. Removal of evacuation of hematoma as per guidelines, decompressive craniectomy and barbiturate infusions. Commonly used drugs are thiopentone infusion at 2 to 4 mg per kg per hour. Hemodynamic monitoring is also needed to prevent the hypotension during barbiturate infusion, and also continuous EEG monitoring is required. Gradual tapering of infusion has to be done if ICP remained in control. These are some CT scans which required surgery. The outcomes at our institute, the mean ICU stay of children was 1.2 days, mean hospital stay was 7.65 days, and the mean GOS at discharge was 4.47. Mortality was 4.8%. These have been some research done at our institute on pediatric head injury last 2 years. We have done a cerebral perfusion study on the functional outcome of pediatric head injury patients, and also we have done a prognostic factors and outcome of surgically treated supratentorial versus infratentorial epidural hematomas in pediatrics, a study of 350 patients. 10 to 25% of patients with mild head injury have persistent cognitive impairment. Cognitive dysfunctions include attention deficits, mood disorders, chronic headaches, poor academic performance, and seizures, and many more disabilities affected by family environment, parenting style, demographics, socioeconomic status. So prevention and safety measures are important. Wearing a helmet in outdoor sport, keeping your child at home, bed safety, car safety, use belts, having this NSI initiative, Safe Balcony, Safe Child. We support this initiative by the NSI, and this is our department. The number of faculty members is 22 in our department, and these are our residents, 14 per year. Thank you for giving attention.
Well, Dr. Manish, you said CO2 level should be 35 to 40.
Yes.
Isn't it higher?
No, it is not high, sir. It is as per the Brain Trauma Foundation guidelines. It should be normal
Upper limit is 35, not a 40.
No. Hyperventilation should only be for very short periods.
Okay. And
because if hyperventilation is given and carbon dioxide falls below 30.
30 is too low, but 35 up to 35, 30 to 35. You mentioned 35 to 40.
Yes.
40 is too high.
That is the normal cardiac level, sir. If you want to give hyperventilation, it should be very short periods, because if we keep persistently the PCO2 at low level, it will lead to cerebral ischemia. Because there will be fall in cerebral perfusion pressure.
Okay. Any question?
It's a very good number that you showed. I mean, I was surprised by 1,100 patients in a year and 1,000 patients 2022. Only pediatric head injury you're talking of. So you just listed the Brain Trauma Foundation guidelines in a row. Are you doing all of these? Like, are you doing ICP monitoring for all your patients? You're not doing, and EEG, etc. You spoke. So how do you think your practice? Because your outcome was relatively very good. ICU stays just 1.5 days. So you're admitting, I guess, then mild to moderate injuries
no,
as well.
Mild to moderate we are not admitting. We have
okay.
the load is so high that as soon as the patient is stabilized, we shift the patient to a semi-ICU kind of thing.
Step down ICU.
Yes.
Okay, because that's what I was very surprised with the number of the days of ICU stay for a pediatric patient, especially.
That is the average actually.
The mortality also
is,
okay.
Yes, sir. Sir, we have this. I mean, this is the Brain Trauma Foundation guideline. We have made it a point, if a children with a fracture comes with a scalp hematoma, he must be given a blood transfusion, even if the hemoglobin report is awaited. So that helps to keep the mortality down. We have it in our experience.
No, but the scalp hematoma with a skull fracture can be a mild head injury also.
Yes.
Those usually do not have mortality per se, I would say.
Yes.
But
in
our practice in general, we would wait for hemoglobin values to come. The mortality we talk is in terms more of severe TBI patients.
Yes, but you see, 39% of patients die due to accident. This is not my study.
May I now invite Dr. B.K. Besh to talk about evolution of treatment of head injuries.
Good afternoon to all. Okay. Thank you for the organizer for giving me this opportunity to talk to this subject with this August audience. Actually, my these topics will be a revisit of the historical perspective, how this treatment of head injury gradually evolved. There are so many treatment and so many guidelines persisting, and many treatment based on the poor level of evidence, and that outcome, though it is mortality gradually improving, but morbidity etc. that number is gradually increasing. So kidney injury, as we know, that among the earliest neurosurgical problem faced by the ancient physicians and surgeons, and earliest neurosurgical procedure was the everybody knows that the trephination, which modern scientists also nowadays also, till now it is practiced. It was used to treat the skull fracture in some civilizations. Egyptian papyri of Edwin Smith provided a thorough description of 27 head injuries in the early BC areas with absolute observations of clinical signs and symptoms, but little information on the treatment of these injuries. Actually, Hippocrates has offered the first classifications of skull fractures and discussion of which types of required definitions, in addition to the redefining these techniques. Hippocrates was also the first to understand the basis of increased intercalary pressures, which actually hypothesized the first ICP monitoring concept by the Hippocrates. After Hippocrates, the physicians of Alexandrian school provide further insight into these clinical evaluations of patients with head trauma, including the rudiments of Glasgow coma scale. Those who are practiced nowadays, that time also that coma scale was practiced, but it is a very redundant type of. The achievements in the treatment of neurotrauma over the years was been tremendous, yet there is so much we have yet to know about the mechanisms and the factor associated with it. Before scripts have been documented, archaeology has been the main source of information. Revealing is the first insight into the intricacies of the neurotrauma. One of the first pieces of evidence of brain injuries in the human was found in the Tanzania, where the injury appears to have been caused by the crocodile bite. However, the first anthropological signs of TBI treatment was attributed to the Neolithic area. That time, that injuries was inflicted by the trauma, and they are doing this removal of these skull fractures. And although the trephinations reached their peak in the Andres and in the ancient Peru, the many ancient cultures from all over the world, including Europe, Asia, Africa, America, etc., have experimented with these trephinations, and that practice being continued till today's. In ancient Egypt, one of the most outstanding progress in the field of neurotrauma research have been documented in the Edwin Smith papyrus. The first written documentation of this brain injuries, the first known surgical treatment treatise, as well as the first medical documentation found in the history in the ancient Egypt. The papyrus was the showcase the symptoms and the diagnostic procedure in patients with the TBI, although with the therapeutic principles and prognostic detailed in the specific cases, including the mentions of the spinal cord injuries with categorizations. It was published in details in the publications, and the papyrus gives the insight into the high incidence of TBI at that point of time, showcasing the fantastic observational skill by these physicians who was responsibility of the treating the patients. And documentation mentioned four types that thus today also we practice in the classical presentation: the title, the examination, diagnosis and treatment, and the classifications of the fractures they have documented, that it was the split, smash fractures, compound fractures, and communicated and depressed. Papyrus is also based in examinations, logical analysis, and deductions, reasonings, and it portrayed the 48 cases of trauma by the anatomic regions, and 27 of which was the head injuries. Then next generation, that Galen is a physician of fallen gladiator, he subsequently contributed to the understanding of the neuroanatomy and neurophysiology. And he was described his own classifications of systems of skull fractures and that further redefined the surgical technique and definitions. According to the history, the accurate and clinical examination of patients, Ebenezer divided the brain tumor that injury into 4 phases. That I forgot. He have graduated when the time today also called with the time is precious. He divided the 4 stages depending on the time of arrival to the hospitals. The Persian neurosurgery history was been estimated to the 3rd century before the Christ, and when the archaeologists found a skull with a triangular surgery scar that belongs to a 13-year-old girl suffering from the hydrocephalus. Evidence and therapeutic approach to the brain injury was he categorized the brain injury treatment into the 3 subclasses, including the tropical treatment, dietary administrations, and oral medications and manipulations. Tropical treatment and the brain boosting drugs, he's analyzing, giving the tropical analgesic medications and brain hypothermia. In that time also the hypothermia was gradually evaluated. Then the Hippocrates area started, and one of the most outstanding figure in the history of medicine is considered by the father of medicines. He was the first physician to perform the systemic approaches to the brain tumor in the injury patients. On his work is on injury of the head. This is published already by documentations. While the Edwin Smith papyrus classified the head already I mentioned, and another interesting aspect of is that he gave the 3-day deadline for definition, because otherwise the patients would be die from the suppurations, and the limit today is known to be the turning point from which the chances of infection increase dramatically. Now also we expect that after 3 days, 72 hours, infection rate is increased tremendously. Hippocratic concept that formation of pus is a prerequisite for the normal wound healing dominate the surgical practice until the regenerates. The Galen was the first to strongly repudiate the Hippocratic concept and found his great contributions to the anatomical and the physiological studies. In contrast to the Hippocrates, he proposed to always rule out the comminuted fractures and supported the Celsus in making whole to find the depressed fractures. After Galen, the other follows the great the Populus is a great Greek physicians who moved to the Rome and continued the compiling and putting into the writing. Then writing literature start from this age, and knowledge is come to the for the clinical publications. In the 6th volume, he had postulated the 6th volume. He talked about the surgery and described a drill for definitions for the first time. It's called the adaptista, which stopped automatically on impact with the bone of protuberance. The modern era, the era began actually in the 15th and 17th century that makes a cultural movement determining the growth of science and culminating in the late 18th century with the beginning of the contemporary history. The Carpi was the noted reference of the 16th century. His interest on the neurotraumatology was clear, and especially with the entity commotions, so that he wrote a monograph on the subject. Andrea de Croix was another resonance figure who published a work in general surgery and traumatology in 1557. He developed the concept of concussions. The concussion term actually started from the 15th century. Ambroise Paré was another great contributor to the brain tumor injury, and most famous and prestigious French surgeons of that time. The importance of dilated pupil by the third cranial nerve was reported first time by the Richard Bright in 1831 after a confirmation through the autopsy for the EDS patients. In the 18th century, the real clinical pathological distinctions of commotions and concussions and compression is introduced by the Bouveil in 1674 and continued by the Jean-Louis Petit. Dupuytren introduced the term concussion. He was also the first to describe the ICP increase due to the EDS. So trepanation was imperative. Management of concussions in the 18th century was very controversial. Francois in France and Louis 15 physicians and the Pott in England advocated the prophylactic trephining if there was much of localized signs such as pain, and while others treated it conservatively. In 19th century, that evolution takes place the great advantage of knowledge of neurological functions, and its brain localization began in the 19th century. It is only recently that head injuries was classified by their neurological deficit rather than the type of skull fractures. John Hutchinson first reported a dilated pupil, Hutchinson pupil we are called nowadays, dilated pupil on the same side as the intracranial clot, and pointed out that it was due to the compression of the third cranial nerve. The discovery of bacteria and development of asepsis and enterosis as well as the anesthesia gave the final momentum for the further growth of and the study of the head injury. The turning point in the 20th century, the outstanding figure of Cushing, and not only he's perfected the technique, is known for the head injuries in the early 20th century, but also he founded a subspecialty as neurosurgical discipline in his work presented at the Academy of Medicine in Cleveland. But the greatest contribution made in this century to the history of the head injuries correspond to the creation of the Glasgow Coma Scale. After the Glasgow Coma Scale, the whole concept of clinical observation is changed, and all over the world the same language of consciousness is level in the same language. The key was that the many of those deaths were prevented and were due to lack of detection of complications in time and manner. This led to the creation of subsequent publication of the Glasgow Coma Scale in 1974 by Graham Tisdale and Brian Jennett. In 1977, it was applied and validated to define the severity of injury. That marked a whole historical moment in the clinical assessment of these patients and determined a great impact. The scale was validated also for a non-traumatic comatose patient in the same year. Glasgow Coma Scale, though it is a turning point, undoubtedly the most important prominent contribution made in the 20th century to the history of brain injury. Through this universal, simple and practical language, it allowed the assessment of brain damage caused by any etiologies. Glasgow's Coma Scale defined coma severity and determined a prognosis in patient with brain damage. A landmark study indicated that the anti-seizure medications, that first anti-seizure medications that phenytoin given within a day of the injury prevent early seizures but not late post-traumatic seizures and post-traumatic epilepsy. So when that paper comes, it concludes that the phenytoin exert a beneficial effect by reducing the seizures only during the first week after the severe head injuries. It was published in 1990. That is also one landmark contribution or evolution that seizures can be prevented in the first week of brain injury patients. In 1990,
You
Macallan working. Time is past. Yeah. Okay.
over time.
Okay. Then I miss this thing. Then evolution again start from the ICP monitoring. In first paper was published in 1951. That is also a turning point for the evolution of brain tumor brain. And next, there is big evolutions for the treatment of injuries. That is the decompressive craniotomy. When it is published, then despite the controversy, the use of DC has been introduced in the TBI guidelines and its efficacy has been recently considered to be beneficial in terms of improvement overall survival as a last tier therapy compared to the medical treatment. Another big sense in the treatment of injuries, that is the invention of the CT scan. The invention of CT scan, they have offered that, given the Nobel Prize in 1979. After the inventions, then whole concept of treatment and observation and diagnostic procedure of head injury is changed all over the world. There are so many publications that I am not mentioning. In conclusion, although there is a lack of evidence of treatment of injury recovery today, the effort for developing the therapeutic strategies of TBI recovery have been continuously made over the past several decades. Standard medical and surgical intervention always play a significant role in the acute management of TBI patients. Given increased population of TBI survival due to the advent of better acute management guidelines in the acute phase of TBI, the number of TBI survivors with various disabilities has also risen. Thank you. Thank you.
Thank you, Dr. Bash.
Yeah.
You have given very nice presentation, starting from.
There is actually a long evaluation
It's
list.
a long. Yeah. But the thing is, what was commotion? Like you mentioned that consciousness and in one slide, commotion. What was commotion?
They have mentioned actually commotion, next concussions. Before the concussion, they produced a commotion. Maybe confuse 1 or 2 seconds, then become all right. It was published in their language.
But now we are not using it.
Not using, absolutely not using.
Right. Any question?
Actually, sir, I have also, in fact, my paper also deals with something to do with the military neurosurgery. Commotion actually is, when the soldiers were there in the fighting war, the cannonballs used to go from the side. So even that wind also would cause them to be a little bit disoriented. So there were no signs of external injury, but they would appear little, disoriented and little semi-conscious kind of a thing. So that period when they would recover back, that used to be called as commotion.
Maybe.
Because वो जब गोला बारूद होती थी तो भागा दौड़ी मच जाती. People used to be running around. So some of them could be sitting there like dazed rabbits. They would not know what to do when this thing is going behind. So that was a transient period of disorientation which would recover back. So that is called commotio.
Okay.
And concussion was when they had an injury, they could see them, they were being hit, but no other external signs of injury. Probably that. There were no clear-cut definitions.
I also confused. I also actually checked in the dictionary, actually commotion literally meaning, what is the meaning? The meaning is nothing to do with the medical term.
So the other speakers of the session are currently unavailable. Dr. H.S. Batoi, Dr. Jitendra Shekhawat, Dr. Gaurav Kakkad and Dr. Raj Gonia. So I think we'll be moving on to the free paper session, and the chairpersons for that session will remain same. So first I would like to invite Dr. Tarunesh Sharma to present pediatric cranioplasty outcomes.
Good afternoon, everyone. My topic is long-term outcomes in pediatric angioplasty. This is research I did when I was in AIMS last year. So pediatric cranioplasty is quite challenging. Resorption rates are high in autologous bones, while infection and exposure are high in alloplastic materials. While the data is very sparse and about long-term outcomes, short-term results may be good in some patients. So our hypothesis was that bone flap resorption is inversely related to age group, and the resorption score is a good indicator of predicting outcome. So the objective was to look for bone flap factors affecting outcomes in pediatric cranioplasty of bone flap resorption, infection, and cranioplasty revision. We collected data over 10 years. Around 155 patients were taken, and the outcome measures were taken as OLU resorption score. So this OLU resorption score is something to calculate it. First, we would like to calculate the volume, which I calculated in this way, as you can see in the video. First, we retrieved the CT images, DICOM images, and then converted them to 3D STL images. Took the cranioplasty sizes, and then after cutting these 3D STL images, converted them in materialized magic software, as you can see in this video. In that software, we could see that what is the volume and surface area of the cranioplasty flap initially and after. Yes, so the right side shows the volume and the surface area of the flap. So this is the overall resorption score, in which the extent, severity, and focus of the bone flap is seen. And then if the score is more than 4, it is considered as significant. So for continuous variables independent t-tests and for categorical chi-square tests were used. We did univariate and multivariate regression analysis to look for predictive factors. So around 155 patients were taken. Mean age was around 8. Females were slightly younger, but that was not significant. Time to cranioplasty was around 6 months mean, and the mean follow-up was 22 months. So most of the patients had autologous bone graft, out of which 72% had cryopreserved, and rest were kept in the abdominal bone. And only 3 patients underwent mesh cranioplasty. So 90% had post-traumatic hydrocephalus, 12% SDH or EDH, 9% infection. The long-term, 73% had resorption. Unfortunately, 3 patients died due to post-traumatic hydrocephalus. So when we did a multivariate analysis for infections, in the final multivariate model, PMMA have 63 times more chances of getting infection than the other material, because the OR was 62.9, it being a categorical variable, it is 63 times more chances of getting infection. In the revisions in multivariate analysis, the patients having RTA, seizures, and tracheostomy were having more revisions than the other. And as we can see, the volume of the cranioplasty bone flap decreased over time, and the surface area also decreased over time. And this is a radar chart showing the OLU resorption score of the 37 patients who had long-term follow-up, in which the center is the ORS score of 0, and as we go out of the circle, each circle has a score of added of 2. So as you can see, the turquoise colored that is the resorption score at more than 4 years, and you can see most of the patients had resorption score which was significant at around 4 years. Bone flap resorption age was considered as the most significant factor, and patients having less than 7 years were having more chances of having resorption than 32 times more, because OR here was 0.026, 32, so they were having 32 times more chances of having resorption than children having age of more than in the age group of more than 7 years. So with each advancing age, bone flap resorption risk decreased by 35%, as the OR here was 0.65, and so we concluded that bone flap resorption is inversely proportional to patient's age. The scoring did not show which we did not show any significant relation with the revisions. So in our study, compared to some previous studies, the mean time to cranioplasty was higher, and infection was almost the same, in fact lower than most, and the resorption score has been in various studies reported from 21 to 80%, but there is a very limited data on pediatric cranioplasty. This ROC study is the highest multi-center study which has the highest number of patients. It was a multi-center study. So we concluded that bone resorption was inversely related to patient's age, with less than 7 years years having high resorptions, and infections were higher in patients having bone cement in children, that is around 63 times. Thank you.
Revision in this after resorption. Revision cranioplasty. You did in all cases.
No, sir. Revision cranioplasty, I've shown here that revision cranioplasty was not done in most of the case. Only 17 patients were done revision cranioplasty. Most of the patient, I mean, in our follow-up, only 17 patients underwent cranioplasty. Maybe not all patients who required had revision cranioplasty. That is what.
And how much time would you waited for? 4 years, maximum 4 years.
So maximum 4 years. Around mean of 22 months I have averaged, because most of the patients were lost in follow-up.
Okay.
So the maximum follow-up period was around 59 months, and the mean average that for resorption which I have taken, that was only 37 patients I could follow.
Did you compare the resorption rates between the cryopreserved and those preserved in abdomen?
Sir, not independently. I just calculated around multivariate analysis. On that, it showed that the patients having bone flap, bone cement, that was in multivariate analysis, that showed 63 times more chances of having infection than other.
What about infection in those patients in which the bone flap was cryopreserved as compared to the abdominal preserved?
So that I have not done.
Okay, thank you.
Thank you.
I would now like to invite Brigadier Shashivardhan for his talk, Heroes of War Neurosurgery, a tribute to forefathers of modern neurotrauma.
Good evening, everybody. I won't take much time of yours. Thank you, Chairperson, sir.
We'll not give you much time.
Aaj tak sabse tej. I promise. So what's special about the military neurosurgeon? Good evening, everybody. Hippocrates wrote, "He who becomes a surgeon should join an army and follow it." What they don't teach you in class or write in books is asked by the patient. And what is neither taught in class, written in the books, or asked by the patient is posed in war. So the military neurosurgeon. Battlefield has provided a fertile ground for the genesis, evolution, refinement of the science and art of neurosurgery. Moving to slow impact to high velocity wounds to the blast induced continues to challenge scientists like never before. The current practice of neurosurgery owes some of its contributions to the military surgeons. So the aim of this presentation is to highlight the contributions of an elite subset of men of science who donned the military uniform and worked tirelessly with the sole agenda of saving lives regardless of one's own safety or well-being. The cumulative efforts of these selfless men working in different time zones gave an unprecedented fillip to the neurotraumatology, helping in translation of this niche specialty from bunker to the bedside. So the two parts of this presentation, part one is the timeline, evolution of surgery in the battlefield, and second is individual contributions of the military neurosurgeons across the globe. The first part is already covered by the previous speaker, so I won't dwell much upon it. We have evidence of Trifine 8,000 to 6,500 BCs as a treatment modality. Edwin Smith Paparus described the first term brain and also treatment of spinal cord injury. Galen insisted on anatomical localization. Al-Razi described the concussion. Albucasis wrote a treatise on neurotrauma with a 30-volume book. It was in 1543 that Vesalius insisted on human cadaveric dissection, and that opened the realm of anatomical localization. Interestingly, there was one Dr. Robert Liston, who was the fastest surgeon known then, wherein the speed of surgery could be reduce the mortality by 15%. So he would say, "Time me, gentlemen." He did an amputation in 2.5 minutes. And this was the only surgery performed which had 300% mortality. The patient died, the person who was assisting him cut his finger and he died of sepsis. And one of the audience, he saw this and he died of shock. GHB MacLeod in the Crimean War was the first one who gave the large-term data on combat injuries and also the role of nursing care in reducing mortality. The American Civil War showed the dawn of modern neurosurgery. Mortality was 45% because of penetrating head injuries and 57% because of trephinations. First time anesthesia came into use during the war, and also there was increased knowledge about cerebral localization. Lister is known as the father of modern neurosurgery because it changed, got a paradigm shift in the mortality and in the surgical treatment. In 1913, World War, 29 brain surgeons were graduated and they were launched into the battlefield because there were a lot of head injuries which needed to be treated. World War I saw a 63% reduction in the mortality from penetrating head injuries, and this ushered the modern era of warfare. Also came in the development of chemotherapy for cancer treatment. World War II saw the introduction of penicillin. Mortality from penetrating cranial injuries reduced to 14%. This is one of the interesting texts dated 2nd of March 1945, where they have described the cranioplasty using a metal called tantalum. And also on this side you can see one of the techniques of doing a cranioplasty using a split bone graft. Pneumoencephalogram and angiography also came into being, wherein they would inject air to see the ventricles, and a dye called diode rust. In 1940, people understood the concept of getting the patient to treatment as early as possible by the introduction of mobile neurosurgical units. So this brought down the infection rate by around from 25 to 5%. The 1950-1975 Korean War and the Vietnam War further reduced the mortality, fatality from 4.5 to 2.5%. It changed the Army's medical doctrine from mobile ambulances to heli evacuation. The Korean War saw a great opportunity for study and advancement. Introduction of vascular reconstruction, artificial kidneys, lightweight body armor, anticoagulant therapy, sedatives, use of albumin, all came into being. And the best part was, from then on started the maintenance of computerized data on this trauma. CT scan had come much before into the being, but the Israelis during the Lebanese conflict, they decided, it was then that they came to know, the protocol was made that routine CT should be done for head injuries, and this brought down the numbers of surgeries that would be done because the CT would decide whether surgery has to be done or not. Then in the 1990s came the Afghan war, wherein there were use of improvised explosive devices. So the mode of mechanism of injury also changed. Initially it used to be penetrating missile injury, now it was blast injuries. So then came in the shift from early to aggressive decompressive hemicraniectomy. Now what's going to be the next battlefield? This one is going to be the outer space. Outer space is now recognized as a priority domain of the national military power. Americans are there, Chinese are trying to reach there, Indians are also trying to make the Gaganyaan reach the moon. So that's where we are slated for. So refinement and management of gunshot wounds also came through the evidences which were brought out in the battlefield. And to assist, we had sectional images, judicious debridement of eloquent cortex, endovascular technologies, and guidelines. Individual contributions, the previous ones I won't dwell much upon it. Hippocrates categorized head injuries, trephinations over sutures not to be done, cerebral localization. Richard Wiseman, 16th century, incision of the dura for SDH, contrary coup, informed consent. Brigangiario da Capri came up with the craniotomy drill. Sushruta, the father of Indian surgery, systematically divided neurosurgery into two distinct fields. He described CSF rhinorrhea and also reduction of cervical dislocation. Ambrose Paré, the father of French surgery, changed the wound dressing technique. Initially they used to use a lot of burning oil. He changed it into elderberry oil and turpentine, which reduced the mortality. And also introduced the concept of surgical hemostasis by using the pincer crow's beak. James Guthrie, an English army surgeon working with the Napoleon, described the plantar reflex effect of positioning in reducing the intracranial pressure. And incidentally, the third line you see, he expresses his regrets that we had not another battle in the south of France to enable me to decide 2 or 3 points of surgery which were doubtful. And he described the pathophysiology of epidural and subdural hematoma. And like the previous speaker, he said that commotio, it is that wind of cannonball which suddenly fires before the soldier's death and makes him little confused. Baron Larry was there in the Napoleon campaigns. He introduced the concept of flying ambulance, and he also developed the concept of triage. From the Russian side, we had Nikolai Ivanovich Pirogov, the first to administer ether anesthesia on the battlefield. This last part you must read carefully. In the Crimean fort, he was supposed to be such a gifted surgeon that the Russian soldiers were convinced that Pirogov possessed almost supernatural abilities as a surgeon. On one of the occasions, a group of soldiers brought a wounded comrade to a medical post. Seeing that the man had no head, the doctor on duty exclaimed, "What are you doing? Where are you taking him? Can't you see he's got no head?" "The head is coming behind us," the men responded. "Dr. Pirogov is here. He will put it back somehow." What about spine surgery? Spine surgery got a better footing in World War II. This was due to the advancement in anesthesia, lightning, hemostasis, antisepsis, coupled with understanding of physiology. Paul of Aegina, radiography, antibiotics, blood replacement, surgeons in the spine became more aggressive. William Williams Keene Jr. was supposed to be the first brain surgeon of United States. He was the famous Keene's point, which we use for putting our ventricular drains, ventricular taps. And the period of American Civil War, more aggressive and rapid surgical interventions by the military surgeons started. Barony, World War I's surgeon, is credited as the first one to report primary closure of non-infected wounds. Harvey Cushing's, lot of literature, but the bottom line is he reduced the mortality in war injuries from 50% to 29%. So Hugh Cranes, he was supposed to be the gurus of people who came up with the Glasgow Coma scale. He was the one who introduced compulsory wearing of crash helmets and brought down the reduction in mortality by more than 50%. And it is after that that helmets became compulsory, first in UK and then all over the world. He was also the first proponent of usage of penicillin in war. Sir Victor Horsley, Cushing's triad, and a lot of studies in missile ballistics in animal models. From India, Brigadier Honorary Dr. B. Ramamurthy, he was the first to recognize the importance of specialized head injury units to improve the standard of care. His scientific research work pertaining to prevention of head injuries, strategies to reduce mortality, management of intracranial hematomas, growing pulse fractures, and post-traumatic psychological effects had the scientific community around the world look back to India in awe and respect. Late Captain Dr. T.S. Kanaka, also known as the Queen of Neurosurgery, she was the first neurosurgeon and the third one in the world who has done pioneering work in stereotactic surgery, the first neurosurgeon in India to perform electrode implants in brain. And her name is also incidentally in the Limca Book of Records for having donated blood 139 times. Also in the field of rehabilitation, Dr. Howard Kessler and Colonel Howard Rush clearly demonstrated the effectiveness of physical medicine in rehabilitation of injured pilots. And herein the concept of the broad specialty of physical medicine, or which we call as rehabilitative medicine, started. So the military neurosurgeons were forebearers of neurotrauma care. The do's and don'ts that the modern neurosurgeon today practice as evidence-based medicine at one time were posed and practiced by these war heroes. Moving on from refinement of operative techniques to prevention to rehabilitation, these men embraced virtually all aspects of neurotrauma. List may not be complete because I couldn't get the complete literary evidence. So to conclude, Hieronymus of the 16th century said, "I would remind you again how large and various was the experience of the battlefield, and how fertile the blood of the warriors in rearing good surgeons." So were the military neurosurgeons extraordinary? The answer is, there are no extraordinary neurosurgeons. It is just the extraordinary circumstances that the ordinary neurosurgeons had to deal with, which makes them extraordinary. War is good for these surgeons, but bad for humanity. Albert Einstein said, "I know not with what weapons World War III will be fought, but World War IV will be fought with stones and sticks." This was Aaj Tak Sabse Tej, but anybody who wants more details, there's a chapter in a book which I've written. I'll be ready to share it with you in case you're interested. Thank you. So being from the armed forces, I thought of giving a tribute to all the military neurosurgeons across the world.
Yeah, it was very good. And you have given a lucid description of all those.
So,
any question from
any
anybody,
questions?
sir? Thank you, Dr.
Thank you, sir.
So I invite now the last speaker, Dr. Saurav Kumar. He will be talking about the neuropsychiatric comorbidities in traumatic brain injury.
Good evening to respected delegates, my dear colleagues. I am Dr. Saurav, second year student in Department of Neurosurgery. I will be presenting today's prevalence of neuropsychiatric comorbidities in patients with traumatic brain injury. This is a part of my ongoing thesis. Neuropsychiatric impairment is caused by TBI directly interferes with the work and activities of daily living, relationship, social image, and impose an economic burden on the society and the nation. Mild and moderate TBI patients are largely neglected and undertreated in Indian population. Therefore, it is necessary to establish the prevalence of neuropsychiatric impairment among the mild and moderate head injury patient. Early detection of neuropsychiatric impairment and remedial measures as well as treatment have important clinical and social significance. So aims and objectives are first to study the prevalence of neuropsychiatric comorbidity in patient with traumatic brain injury, and second is to evaluate the quality of life in patient with psychiatric comorbidity following traumatic brain injury. The study design was prospectively observational studies. Sample size that I have enrolled till now is 20. Study was conducted at Trauma Center, Jayaprakash Nayan Apex Trauma Center, and duration of study of enrollment of patient was from September 2022 to January 2023. Inclusion criteria that I used in this thesis was the all patient who presented to trauma center between September 22 to January 2023. Exclusion criteria was patient who had severe TBI, Glasgow Coma Scale 3 to 8, age less than 18 and more than 65 were excluded. Patient with known psychiatric disorders of any drug abuse or any psychiatric drug intake, they were excluded. Patient with previous neurological disorders and patient with post-traumatic aphasia. Because the scales that we used to analyze psychiatric comorbidities requires patient verbal output also. So all these patients who were enrolled were studied after 6 to 8 weeks of period. The scales that I used in this study was WHO Qualbrave. It is a qualitative assessment of overall quality of life faced by the survivor of traumatic brain injury. Modified overt aggression scale. Aggression is most common comorbidities among psychiatric disorders in traumatic brain injuries. Mild and moderate TBI patients, often caregivers they complain that the major concern in managing these patients are that they are very aggressive in their post-operative period. Prime MD is a scale which is used to find out depression amongst the patient. It is basically WHO designed primary health questionnaire PHQ. PHQ 9 is used as prime MD scale. And Edinburgh Cognitive Examination Scale ACE3, it is used to, it has subdomains also. It has 5 subdomains like attention, memory, fluency, language and microspatial analysis, and a total score of out of 100 is given, based upon which we find out which domain the patient is having impairment. And so up till now the age group, age distribution, we had 8 patient between 18 to 24, around 12 patient, 11 patient from 24 to 50, and 1 patient was more than 50. Around 80% of the patient enrolled were male. Now depression, which was analyzed with prime MD scale, it has 4 categories: mild, moderate, moderately severe and severe. Mild is when the score is less than 5, moderate is between 5 to 10, moderately severe between 10 to 15, and severe is more than 20. So most of the patient of mild and moderate brain injury, they were under the category of moderately severe and moderate brain injury, moderate depression. Now cognition, it has subdomains also, 5 subdomains, but the most common, I will be describing this later also. Around 60% of the patient, they were cognitively performing well only 40% of the patient had ACE score more than less than 82. So 82 is taken as cutoff of Edinburgh Cognitive Assessment Scale. Less than 82 is considered as cognitively impaired. So around 40% of the patient enrolled till now out of 20 were found to be having certain degree of cognitive impairment. Now this is the modified overt aggression scale. What we found out that this is the most common comorbidities in psychiatric term suffered in the patient. It has various subdomains like verbal aggression, aggression against property, auto-aggression, and physical aggression. And based upon this scoring, weightage is given. Like verbal aggression, we calculate the score and this is multiplied by 1. And aggression against property, we multiplied by 2, auto-aggression by 3, and physical aggression by 4. And one thing which is very peculiar about this scoring, that you can select as many responses as you can. Like it's not like you can select only 1 or 2. You can select 1 also, 2 also, 3 also. There's kind of additive score. And there is no cutoff. And in analysis, one time scoring is not of much significance. We actually follow up after a period of time and we see how much the score is changing. So aggression in TBISH was analyzed by modified overt aggression scale, verbal aggression, aggression against property, auto aggression, and physical aggression. So 17 out of 20 patients analyzed till now showed one or other form of aggression. Average MOAS score calculated in 20 patients was around 21.5 and total score comes around 44. So take home message, this is still a part of ongoing thesis, around 6 to 8 months more to complete. Cognitive impairment is one of the most common culprit influencing the long-term neurological outcome following traumatic brain injury. Executive functioning like language, memory were more frequently impaired subdomains of cognition. Aggressive behavior is one of the major post-traumatic sequelae. Mild to moderate depression is not very uncommon in traumatic brain injury, even if they seem to be perfectly normal. Thank you. Yes, sir. So this is the study is already ongoing. We are planning to repeat this examination again after 3 months, and we will see how much the score is changing.
So when are you examining your patient? You said 6 to 8 weeks.
After a time of trauma, ma'am.
So after the patient has
recovered.
No. Date of injuries.
So you are including your mild and moderate.
Mild and moderate. We are excluding the severe.
So you're excluding the severe. So mild and moderate trauma patients comes to you from the date of injury to 6 to 8 weeks.
Yes,
that is the first assessment that you do at the 6th to 8th week.
Yes, ma'am.
Correlation between the aggression and all this other cognitive parts and the part of the brain which is injured.
Yes, sir.
Like frontal lobe, lobar injuries. What is the kind of thing? Any correlation? I'm not asking for the definite
Sir,
results.
what we have seen till now, that patients who are having frontal contusion, basic frontal contusion, and frontal lobar involvement, they are more aggressive. And we are also planning to do DTI imaging and MRI correlation between the symptoms, psychiatric symptoms suffered by the patient, and the exact region of the brain which is involved in this. Of the antisocial behavior.
So that also can be as part of the study.
Yes,
like
sir, this is already
depending on which part of the brain is injured and what is the kind of manifestation and how much time it takes. So
Yes.
that will be in fact.
To have a baseline idea of the patient's behavior pre-trauma also. So maybe documentation. Maybe like he was an alcoholic. He always used to be an aggressive person.
But when we have already excluded that.
Excluded, yes, excluded.
You've excluded alcohol, but you've excluded what else?
Any history of previous psychiatric disorder.
Psychiatric disorder.
Generally,
but it is difficult to take that history, but
nobody goes to a psychiatrist and get it documented that the patient has a psychiatrist. So there should be a questionnaire to assess whether the patient in the pre-trauma phase had psychiatric involvement.
Yes, ma'am.
Okay. Thank you, Professor.
Definitely. Yeah. So with that, we conclude our free paper session, and now we have a 5-minute recorded lecture by Dr. Eduardo Piketty from Italy. He's working in the Department of Anesthesia and Intensive Care. He will be talking about the management of severe TBI in a hospital without neurosurgery, an overview of the 2023 WSES Consensus Conference.
Have a question, please send me an email whenever you want. For this consensus, an hub hospital is a hospital with neurosurgery, where a spoke hospital is a hospital without neurosurgery. Before to start, I don't have a conflict of interest to declare, and I wish to thank the World Society of Emergency Surgery for the support, particularly to Fausto Catena and Chiara Robba, and many thanks to all participants to the consensus. The agenda of my talk is this. I try to speak with you about the background, why you perform this consensus, about the methods, a little overview, and practical conclusion. Traumatic brain injury is a leading cause of mortality and disability worldwide, and generally patients with severe TBI need to be admitted to a hub hospital because this patient possibly need to have a neurosurgery and advanced neuromonitoring. In some cases, for various causes, this patient can be admitted to a spoke hospital, which is a hospital without neurosurgery. And few data are available regarding the optimal management in this setting. And for this motive, we perform a consensus conference with the support of the World Society of Emergency Surgery. And regarding methods, in this consensus, and this is very important, we specifically refer to patients with isolated TBI patient admitted to a spoke non-rural hospital of high-income country with the availability of ICU, operating room, and whole-body CT scanner. This consensus not refer to the management of TBI patient in low-income country. This is a different condition, and in this regard, I suggest to refer the important work of Professor Rubiano and Professor Chestnut. This is an open access article because the World Journal of Emergency Surgery is an open access journal, so you can download the article whenever you want. And you have for this consensus a multidisciplinary consensus panel. We adopt Delphi consensus method. You have in this consensus intensivist, anesthesiologist, neurocritical care physician, acute care surgeons, neurosurgeons, and neuroradiologists. A strong recommendation is considered a recommendation with an agreement greater than 85%. A weak recommendation is a recommendation with an agreement between 75 and 85%. And when we have an agreement inferior to 75%, it is not possible to make a recommendation. We have 25 recommendations, 22 are strong and 3 are weak recommendations. No consensus for 3 statements related to anti-seizure prophylaxis, brain ultrasonography, and automated pupillometry. This is the flowchart, the consensus. Briefly, there are a part related to the communication between the hub and the spoke hospital. It is very important. This communication can be done by telemedicine if available, and is related to the communication between two different hospital and between two different clinical equipe. There are a part related to the respiratory management, to the monitoring, and also the hemodynamic coagulation management, and some maneuvers that are important for the prevention of intracranial hypertension. And related to the transfer to the patient to the up center, this need to be performed by a physician with experience in airway management, with life support strategy, and with basic knowledge in neurocritical care. And most important, and this aspect is related to the good communication between hub and the spoke center, is the direct transfer in the operating room of the patient if the patient need an emergency neurosurgical operation. In conclusion, this consensus was performed to support clinical decision making in a difficult condition and to deliver the best possible care in a situation when there are few data available from the literature for the management of the patient in a spoke hospital. More studies are necessary and are applicable for the future, but in my opinion, the main message of the consensus is to introduce the concept of high-quality perioperative traumatic brain injury. To do an high-quality care, it is important to have an important interaction, an important collaboration between physicians with different specialties. This is very important for the management of the patient, of this patient, and maybe to have a good neurological outcome. Many thanks once again for my invitation, and I hope to see you soon in India.
Thank you, sir. Thank you, ma'am, for chairing the session. I don't think he will be available for the question answer session. Okay. Thank you so much, sir. Thank you, sir. Thank you, ma'am. Thank you, everyone.